Hello, and welcome to our 8th Annual Women's Heart Symposium. I'm Nicole Weinberg, and with Doctors Serena Vanderzee, Alexandra LaJoy, and the other members of the Women's Heart Center of Pacific Heart Institute and the Have a Heart, Save a Heart charity, we welcome you to the symposium. This is our 8th year doing this event, and wow, do things look different this year. Life has changed over the past year, but our mission has not. We strive to bring you an informative meeting with all the bells and whistles. We want today to be a shining light in an otherwise dark year. Today is going to be filled with fantastic lectures, fun gifts, and some surprises.
Many of you have received a gift box. If you haven't opened it yet, now is the time. We invite you to use some of these items during the meeting today. If you haven't received a gift box, you may bid on one now. And in the meantime, gather some similar items from your home so you can be part of the fun. Let's start out with the best way to take care of the latest and greatest in COVID fashion, your mask. In your gift box, you will find a bag to launder your mask and also a mask hanger to secure your mask in your car around the rear view mirror when you get off from work. Clearly, these are things you never needed before, but you need now more than ever to live forever. Since this is a charity function, we are hoping that you will be as generous with your wallets as you have been with your time today. We have some fantastic items, as well as our retreat at the Four Seasons to be raffled off this year on the website Rally Up. As you recall from years past, we have hosted a half-day retreat, but this year there are no risks of cancellation since it will be virtual. If you won this last year, you are automatically included in this year's retreat. If you want to get in on the fun, check out the retreat on the Rally Up page. There are only 15 spots available. We have a host of other fantastic items, including Privé sunglasses, hair tools and products by Gina, custom golf putters, and an interior design experience. Please check out our website and place your bid. Remember, all proceeds benefit our charity and events such as this. Click on the link provided in the chat panel to the right-hand side of your screen now.
Few housekeeping notes. This year, we're providing continuing education credits for doctors, nurses, PAs, dietitians, and pharmacists through a company called Pharmd. The instructions and contact information are in the emails for this event and in the chat icon. Pharmd will distribute all the credits. At the bottom of your screen is a chat icon. Keep your eye on that throughout the event for more information on our programs and raffles. You'll also see a Q&A icon. Use this to submit questions for our speakers and hosts. Part of the program has been pre-recorded, but all of our speakers are present today to answer your questions during the Q&A sessions. You can also use this space for technical questions as our Within 3 support crew is online as well. Now let's get this party started. We'll start with our very own Dr. Weinberg. She's a non-invasive cardiologist with a passion for prevention. She lectures on various aspects of cardiovascular disease, the leading cause of death worldwide, and ways to prevent it. This year has challenged our understanding of mortality, and so she's going to kick things off with a case-based talk on questions to ask your doctor to help you stay forever young.
Good morning, everyone. My name is Nicole Weinberg. I am a non-invasive cardiologist at Pacific Heart Institute in Santa Monica, California. I'm going to be kicking things off today with a talk entitled 5 Things to Ask at Your Doctor's Office to Stay Forever Young. So let's get started. So case 1. So we have a 59-year-old female who eats healthfully, exercises regularly, but wants to make sure that she stays forever young. She asked her doctor for everything at her upcoming physical. Where should she begin? So we're going to talk about this case as it relates to 3 different bullet points: basic blood work, advanced lipid testing, and lipoprotein(a). So for basic blood work, the doctor generally checks things like your liver panel, your blood counts, your electrolytes, your kidney function. Additionally, your basic cholesterol can be included, and that generally includes things like your low density lipoprotein, or your LDL, which is your bad cholesterol, your HDL, or your high density lipoprotein, or your triglycerides. These are all considered basic cholesterol blood work that can be checked at your doctor's office. The American Society of Pediatrics generally recommends starting screening testing of cholesterol between ages 9 and 11 years old, but most adults get this checked annually at their checks in the doctor's office with their physical. So if we think about advanced lipid testing, that's taking the basic cholesterol a step further. That's looking at the LDL cholesterol, stripping the membrane of the LDL, and looking more deeply inside the LDL cholesterol. You're looking at the particles that make up the LDL and understanding where this puts you in your risk profile. So if you look at the patients on this page, there's 4 people shown. They all have an LDL of 125, but you can see the ones that have less particles on the left side of the image don't have as high of a risk, but the ones that have a higher risk have more particles, so the one on the right side of the page. So that person has a higher likelihood of having a cardiovascular event. So advanced lipid testing is not new. It's something that's been around for decades, and there have been over 2,000 systematic reviews looking at risks of cardiovascular outcomes, heart attack, stroke, and death, and these LDL subfractions, or this advanced lipid testing, to be able to understand what will yield a better result for our patients. And we have found that the advanced lipid testing gives us much more information than basic lipid testing alone. So if we take that advanced lipid testing a step further and we look at lipoprotein(a), we consider this to be an independent risk factor of cardiovascular disease. So if you think about cardiovascular disease as a pie, there are a lot of pieces of the pie. There's whether you have family history, high blood pressure, high cholesterol, diabetes, if you're a smoker. Well, lipoprotein(a) is yet another slice of that pie. It tells us if you have this independent risk factor that is a pro-inflammatory agent. And so if you have this, you have increased risks of developing plaque in your coronary arteries. You also have increased risks of developing aortic stenosis or calcification of that aortic valve. So if you have elevated levels of your lipoprotein(a), you are between 2 and 4 times greater risk of having premature heart disease, heart attack, stroke, and aortic stenosis. So those levels as measured in the blood are greater than 50 milligrams per deciliter. So if you have a number in your blood of greater than 50, you are 70% more likely to develop coronary artery disease. So because these numbers are so high, this is now considered to be a malignant risk factor of coronary artery disease. So it's important to identify it in our high-risk patients and then ultimately decide how we want to manage them further. This should be checked in patients that have a significant family history. So men that have a family history of somebody in their family having a heart attack, stroke, or death younger than 50, and in women younger than 60. So these are patients that may have perfectly normal weight, blood sugars are completely normal, blood pressure and basic cholesterol numbers are normal, but they will still have an increased cardiovascular risk if they have an elevated lipoprotein(a). So in terms of treatments, so this is where there's a lot of research going on. As of right now, there are no good therapies, but there are some medications and supplements that can lower the lipoprotein(a), although minorly. Things like niacin and the new injectable cholesterol medications like the PCSK9 agent can lower your lipoprotein(a). A lot of the research right now is looking at whether you actually lower it in your blood. Are you improving cardiovascular outcomes? So are you lowering the patient's risk of having a heart attack, stroke, or death? Right now, the jury is out. We do not have good data to support lowering the lipoprotein(a), but what we do have is good data to support lowering all the other risk factors to quite low levels, such that we reduce the likelihood of progression of disease from those other pieces of the pie. So in conclusion, it's very important for you to know your risk factors of disease, and this can be found out through simple blood work. You also want to have your lipoprotein particle number or your lipoprotein(a) checked for patients that have a significant family history of cardiovascular disease. And the treatment options are in development for lipoprotein(a), but we do know that lowering your risk factors, including lowering your LDL, seems to be the mainstay of treatment at this time. So now that we've gotten through case number 1. Let's move on to case number 2. This patient is a 51-year-old female who expresses great concern about her family history of heart disease. She knows that every year when she goes for her physical, her blood work is fine, her blood pressure is fine, her exam is normal, everything is great, but she wants to live forever. So what should she ask her doctor for? So we're going to break this case down into 3 different topics: heart disease statistics, coronary artery disease testing, and the coronary calcium score. So I know we have shown this slide probably every single year, but it's important to just hit home with our basic theme, which is heart disease is a leading cause of death. It is still the #1 leading cause of death in women. It kills more people than number 2, 3, and 4 combined, which are stroke, lung cancer, and COPD all combined. And if you look at this #1 leading cause of death, about 50% of the deaths are related to coronary artery disease. So it's really important that we identify patients with coronary artery disease. If you look at our guidelines within the world of cardiology, there are no screening tests that we use to be able to assess for which patients are at increased risk. Most of what we do is related to stress testing as it relates to coronary artery disease. And so it's important to identify our patients. Now, if we look at stress testing, what are you getting out of a stress test? Well, a stress test is looking for blockages in your heart arteries that are considered to be significant. So a blockage 70% or greater is what we consider to be significant. That's because there are flow changes and different features of a stress test and your body's own chemistries that we can check for that will tell us that this blockage is something significant and requires intervention. If you have a normal stress test, you could still have a blockage that's 60%. And that's something that a lot of my patients would like to know. They're not going to get that from a basic stress test. So if we look at coronary artery disease testing, there are different types of tests that we look for. So stress testing is one, and the coronary calcium score is another. If we look at stress testing, it's a great study because it's a functional test. So we can see what your body looks like with exertion. It's wonderful if you're having some symptoms and there's some concern that those could be related to blocked heart arteries. We can also do this study without any radiation, much of the time on the treadmill or with the echocardiogram machine. If you're having a nuclear stress test, there is a small amount of radiation associated with that type of stress test. With these tests, we're looking for blockages, like I said before, that are 70% or greater, something that's considered to be clinically significant that may require angioplasty or a stent placed and or bypass surgery. If your stress test is normal, the likelihood of you having a heart attack or sudden death related to blocked heart artery puts you in a low risk category for 2 years after your test. So it's all good information, but there might be more. So a coronary calcium score. So this is not a functional test. This is a CAT scan study. So you're not exercising, you're lying on a table and you're going through the CAT scan machine. There is a small amount of radiation associated with this. It's generally equivalent to if you got on an airplane and flew to Las Vegas. But it does tell us if there's plaque buildup in the system. And this is generally why people want to get the study. They want to know if they are depositing plaque. If your coronary calcium score is 0, that means you have no plaque buildup in your system. It means the likelihood of you having a heart attack or sudden death related to blocked heart arteries puts you in a low risk category for 10 years. So that's wonderful if you think about the likelihood and predictive value of screening testing versus a stress test. So a coronary calcium score is something that we are utilizing more and more as it relates to getting this good information from a screening perspective for our patients that are at increased risk of cardiovascular disease. It looks for any plaque buildup. It doesn't just say, oh, your stress test is normal, so we'll see you again in 1 to 2 years. It actually identifies people that are at risk despite how healthy they feel or what their risk factors may show. The only issue associated with this study that is not optimal is that many insurance companies don't pay for this out of pocket. And so it does require an out-of-pocket expense for some of our patients. This out-of-pocket expense in our area is generally less than $200. So it's significant, but most of the time the doctor's office or the radiology center will be able to give you that information before you have the study. So this is what a coronary calcium score looks like. If you look at the picture on the left side, you will see that that's a patient with a coronary calcium score of 0. So we look for white spots in the gray around the middle. The white on this study is rib cage on the sides and spine at the bottom. And you can see that there's no white spots like that in the middle of the gray matter in the middle of that picture. If you look at the slide next to this, this is the same patient 15 years later with plaque buildup. And so you can see that within this gray matter in the middle, you do have some white streaks in there. That bright white is similar in brightness to the spine at the back and the ribs on the side. So that's how you can appreciate that this person has calcification noted in their heart arteries. So what do you do with this information? Well, you get a score with your coronary calcium score, and we use that as a means of risk stratification. So again, if you have a 0 coronary calcium score, we know that you have no hard plaque. But if you have a score of 0 to 100, we assume you generally have minimal to mild plaquing in your heart arteries. And greater than 100, we generally consider that to be something that may be clinically significant. And depending on risk factors and different symptomatology, these positive studies may warrant further testing. The other thing that's really interesting about this report is it gives you a percentile risk. So it takes you as the patient and compares you to other people that are your same gender in your same age group. And so it's sometimes nice to see where you stand compared to the other patients in your age group and your gender. If you are greater than the 50th percentile, that's generally not optimal. And we always are looking for ways to reduce that risk moving forward. So let's say you have a coronary calcium score and it's elevated. You may ask, are there other things out there that can elevate my coronary calcium score? Well, generally, when we look at patients that have an elevated coronary calcium score, 90% of the patients that we look at that have elevations, we generally blame it on the cholesterol levels, the inflammatory risk factors, and some of the things that we've discussed already. But there are a few other things that are interesting that are being looked at in the literature. So one has to do with radiation. And if you think about our treatments for, say, breast cancer, for example, there is radiation to the chest wall, and beneath the chest wall is the heart. So it's not unusual to think that there may be some radiation that hits the heart arteries, the aorta, the valves from these treatments. And it generally doesn't happen right away, but there is a buildup of some irritation to the cells that are hit by radiation. And you can see some of these changes at about 10 years. Radiation therapies have gotten much better over the years, and many of them are much more targeted. So this is something that we follow very closely with our patients, but not to worry or decide that you wouldn't have radiation therapy based on this. A lot of the therapies are much improved compared to where they used to be. Additionally, there are things like environmental toxins. We had spoken a few years ago about particulate matter in the air and how this can have an inflammatory effect within our bodies, particularly our heart arteries. Additionally, smoking has similar particulate matter that has a harsh oxidative property and can cause deposits of plaquing, irritation, and lots of inflammation. And lastly, and this is a category that is very much studied at this time, are patients that do significant anaerobic exercise. If you look at patients that are ultramarathoners or exercise for miles a week by running, they are depositing plaquing in their arteries at a rapid rate. This is something that is being studied quite significantly because the leading cause of death in this generally thought of as healthy patient population is cardiovascular disease. So in conclusion, heart disease is the leading cause of death, and that should be the take-home message. Looking at stress testing is a great test, but it is really significant if you're looking for blockages in your heart arteries. A coronary calcium score is something that may yield additional information because it'll tell you if there is any hard plaque buildup in your arteries that may need to be treated. So moving on to case number 3, we have a 48-year-old female who presents to the doctor's office with concerns that she is turning into her mother. Her exam is normal, her testing is good, but on closer examination, her glucose and triglycerides are higher than they used to be. How can she stay forever young? So in this case, we're going to talk about metabolic syndrome. Why is sugar bad? Recommendations for diet and exercise based on the American Heart Association. So metabolic syndrome. So this is a defined disease process that includes a glucose that's greater than 100 milligrams per deciliter, an increased waist circumference of 35 inches in women, elevated triglycerides greater than 150 milligrams per deciliter, and an elevated blood pressure greater than 130 over 80 millimeters of mercury. So why is it significant to identify these patients? Well, about 20 to 30% of the population in industrialized countries has metabolic syndrome. It has a very strong genetic predisposition, but once you identify patients with this, it's very important to modify their risk factors because they have a 2 to 4 times greater likelihood of having cardiovascular disease than the normal patient population. Generally, a lot of these changes start around perimenopause as some of the hormone levels drop, and those 10 years after menopause starts are when women's bodies change and their risk factors for cardiovascular disease generally become a bit more significant and apparent, and that's oftentimes when we start to modify their risk factors. This is one of the times when checking triglycerides, especially in women, becomes very important. Triglycerides in women are considered to be an independent risk factor in light of this very finding related to metabolic syndrome. So for the purposes of my talk, we're going to talk about how diet and exercise can help metabolic syndrome, which is not something that can be underestimated as to the significance of it. Later on in this meeting, Dr. Wright will talk about some interesting pharmacologic updates as it relates to blood sugar, diabetes, and heart disease. So in the world of the American Heart Association and cardiovascular disease, a lot of what we end up recommending for patients is the Mediterranean diet. So this is a diet inspired by eating habits in Spain, Italy, and Greece from the 1960s. A lot of it has to do with ingesting high good fats like olive oil. There are great studies about how much fish the Mediterranean diet includes. There are wonderful studies about getting protein from plant-based sources like beans and legumes. And these are the reasons why the Mediterranean diet has been so popular within the world of preventative cardiology health. You will notice on this pyramid that meats are very at the top of the pyramid, so those are less often, as are sweets, and wine is on the side as listed in moderation. So just to kind of talk about sweets and why they are so bad has to do with the feedback loops associated with this. So if you look at our patients that are eating about 15% of their calories from sugar, they have a 40% greater likelihood of having cardiovascular disease. So you think about everything that you eat in the day and how it gets broken down in your system. 15% of your calories is actually not that much, but to increase your risks of having a cardiovascular event by 40% is very significant. We're learning more and more as it relates to sugar that things are on a bit of a feedback loop. And there are addictive properties to having sugar. So if you're somebody who maybe likes to have a meal with sweet afterwards, every day you may want that sweet at the same time after your meal because it's something that you're craving. There are a lot of interesting studies looking at the neurochemistry associated with the body when it has sugar and equating it at a smaller magnitude, but to similar responses to drugs of abuse like cocaine or morphine. So it's important to check in with your body and say, okay, why do I want this? Do I need it? Am I still hungry? What is this just that I want this because I had it yesterday at the same time? So that's some of the mechanisms as it relates to understanding why sugar is not so good for our system. Additionally, if we look at the alcohol piece of the puzzle, this is something that I have heard a lot from patients over the past year, that they have been drinking more, and it is something that is a stress relief. It is something that they are doing to manage their day. It's not just for social purposes like it used to be on Saturday and Friday nights. Now it may be most days of the work week. So if you look at the American Heart Disease guidelines recommending sugar in women, you can see that women are recommended to have 25 grams of sugar or 6 teaspoons of sugar during the course of the day. From my perspective, that sounds quite minimal, but if you look at where that lies as it relates to your alcohol, it can be chewed up quite quickly if you're having a few beers or a few glasses of wine at night. So if we look at the slide detailing the beer, if you have a bottle of Heineken, that's 2 teaspoons of sugar. Many people end up maybe having more than 1 bottle of beer. And so that may be something that could completely eat up what you are allotted for your sugar during the course of the day. Wines are a little bit of a different story. Sweeter wines obviously will have more sugars in them. So a sweet wine will have about 2.5 teaspoons of sugar. A white wine will have about 1/4 of a teaspoon of sugar. And that, along with a few other healthful properties, is why the Mediterranean diet generally advocates for choosing red wine over some of these other alcohol substances. But let's just say every night you're having 2 to 3 glasses of red wine at the end of the day to unwind. So that may be close to a teaspoon of sugar at the very end of the day. And it's something that may actually be clinically significant as it relates to weight changes, glucose changes, blood pressure changes, and cholesterol changes. So why do we need sugar? Well, the breakdown of sugar from carbohydrates gives us energy. So these are the things that we use to run and exercise and perform our activities. So please do not underestimate the significance of getting this in your system. Our bodies need carbs and they do need sugar. But let's just say, for example, you're looking at an athlete who is getting ready for a race and they're training for this and they're eating more carbs because they're burning it when they're exercising. That's something that seems like they're using their food as fuel and they're using that to complete their exercise. If you think about how maybe we could be using our alcohol at the end of the day, we're probably not fueling very much exercise or activity. It's something that we're just drinking and sitting and relaxing. And so it's something that I don't think should necessarily be taken out of your diet, but I think it's something that we need to understand the significance of and decide, is this something that I need at this level? As it relates to exercise, just to segue a little bit, the American Heart Association's recommendations for exercise are not complicated. They're saying you should go for a walk about 30 minutes a day for 5 days a week. That is as minimal as you can do, and it does go up from there. You can do more high intensity exercise. All of this exercise is very good for reducing your weight, reducing your blood sugars, reducing your blood pressure, reducing your cholesterol. So again, the American Heart Association does not make it very complicated. Walking every day is very healthy, and also hearkening back to some of the food issues and the blood sugars and the breakdown. I have heard from a lot of people that the recommendations that their dietitians have given them and their endocrinologists are to walk after a meal, because then you're breaking down some of those carbohydrates and sugars that you've just ingested. So in conclusion, metabolic syndrome is a significant risk factor for cardiovascular disease. Be mindful of your sugar intake, including portion control, food choices, and alcohol. And please do not underestimate the importance of diet and exercise to maintain your overall health. So case 4. So we have our 62-year-old female who feels like she cannot get a good night's sleep. She wants to wake up rejuvenated, but instead wakes up feeling groggy. How can she fix this so that she can stay forever young? So we're going to talk about sleep health, sleep disorders, and sleep and heart disease in this case. So sleep health. So you will recall 2 years ago, we had Dr. McGowan come and give us captivating talk about sleep. And she mentioned that sleep was a vital sign. So this is something that we should be focusing on much more significantly as it relates to checking in of our patients. It's not significant just what their weight is and what their blood pressure is, but also understanding how much sleep they got the night before is critical. We need to value sleep because it is restorative, and the sleep disorders of insomnia and some of the other ones that we're going to cover can be very detrimental to the health. Additionally, people need sleep to get through their workday, their jobs, their childcare, and oftentimes people end up turning towards drugs to manage this. And it's also important to realize that a lot of the studies looking at pharmacologic therapy and sleep disorders in women show that the drugs differ compared to our male counterparts, and they may not necessarily provide us with the same benefits. So sleep patterns. If you look at this graph, you'll be able to see during the course of a night, the body is falling in and out of different sleep degrees. So the REM sleep that they have may come at different stages of the night and be different lengths of time, but it's generally known to be important to get this REM sleep. So REM stands for rapid eye movements. The functions of this amount of sleep are poorly understood at this time, but being studied extensively because they contribute to restorative sleep, revitalizing sleep, and reparative sleep. And those that do not have REM sleep are diagnosed with disorders such as obstructive sleep apnea and a variety of other pulmonary disease processes. So sleep apnea. There are two different categories of sleep apnea that we look for. One is central sleep apnea and the other is obstructive sleep apnea. The end result of both of them is hypoxia, so decreased oxygenation. Central sleep apnea has to do with how the diaphragm works, and if it's not working well, you're not taking in enough oxygen through the lungs. Obstructive sleep apnea is the one that we're a bit more familiar with. It has more to do with a soft palate and how it clamps down and makes it difficult for oxygenated oxygen to get into our system so that we can make some oxygenated blood. People that have sleep apnea generally have snoring, gasping for breath, fitful sleep, and daytime tiredness. So there are a lot of changes that occur in our body with sleep apnea. And so a lot of these have to do with different chemicals that get released in our system when we're undergoing these different disorders. So weight gain is one, increased blood pressure, increased cholesterol, and increase in blood sugar. So all of those things put together are bad for cardiovascular health. So certainly identifying sleep apnea as it relates to changes in your body is significant. How about changes in your heart specifically? So if you look at a heart, the normal heart that is pumping blood around your body, the left side is pumping blood through your body, the right side is pumping through your lungs. So over time, if you have a scenario where you don't have enough oxygen, then the right side of your heart will start to work overtime as it relates to getting more oxygen to the tissues and working harder. So it'll thicken and it'll start to dilate. And over time, you'll end up with this right ventricular failure where the right heart is ballooned out. It cannot squeeze well. And ultimately, these are patients that end up with degrees of congestive heart failure. So if we look at patients that have sleep disorders and cardiovascular disease, arrhythmias are a really significant problem as it relates to the hypoxia that patients get. So with hypoxia, as we know, comes structural heart disease issues. Additionally, comes the heart's desire to get more oxygen to the body. And so these arrhythmias start with rapid beats. So if you're diagnosed with something like atrial fibrillation, which is an arrhythmia of the heart, one of the initial workup tools is doing a sleep study. If you look at this chart, you will see the incidence of atrial fibrillation based on the presence or absence of obstructive sleep apnea is double in patients that have obstructive sleep apnea compared to people with no sleep apnea. So you can imagine a scenario where somebody has AFib diagnosed, but then works on managing their obstructive sleep apnea and will either lower their atrial fibrillation burden or perhaps even cure their issues related to their arrhythmia with treatment of their obstructive sleep apnea. And obstructive sleep apnea is not something that is just in older decades of life. There are interesting studies looking at women that are pregnant and sleep apnea. And if you assess a patient who is pregnant who has sleep apnea, you can see that their risks of cardiomyopathy, congestive heart failure, and in-hospital mortality are significantly elevated. So identifying these patients when they're pregnant as to whether they have obstructive sleep apnea and treating them will greatly reduce their likelihood of having an unfortunate event during their pregnancy. So in conclusion, sleep plays a key role in heart health. It is implicated with elevated blood pressures, arrhythmias such as atrial fibrillation and congestive heart failure. And it is not something that is just for our older patients. This is something that younger patients can have as well. So for our final case, case 5, we have a 50-year-old healthcare worker at St. John's. COVID is raging, and she wants to make sure that she stays as protective as reasonably possible. But she does have some reservations about the new COVID vaccine. She wants to live forever, but she doesn't want to harm herself by getting the vaccine. So in this talk, we're going to talk about COVID and heart disease, COVID treatment, and vaccination. So I know we have seen this chart many times over since March, but this is a distribution of COVID cases over the world. And you will see that the Americas as well as Europe have the highest levels as documented on this slide. If we just narrow down our focus to the United States, you can see that as of January 20th, the Southwest, Southern California, as well as the Southeast are having big pockets of COVID at this time, which is obviously quite concerning. And if we spotlight California just for the fun of the sad perspective, we can see our rates in almost every county are going up. It is extremely unfortunate as to what is going on in our hospitals, and there are 0 ICU beds, and based on the county data, it is considered to be widespread in all counties, almost all counties in California. So why is COVID significant for our patients with heart disease? Well, the statistics are not good as it relates to somebody who has heart disease. Now, we define heart disease as people with coronary artery disease, congestive heart failure, and or significant valvular heart disease. And if you have any of those conditions, your mortality rates associated with getting COVID are 10.5%. So that is basically double all of these other risk factors of disease and much more significant than if you had no risk factors at all. What I think is interesting as it relates to this graph is one would generally think that patients with cancer who are on immunosuppressive agents and or have low immunity would have a higher death rate than 5. But heart disease patients end up with double the death rate of cancer patients with COVID. So what can happen to your heart when you get COVID? Well, when you get the infection, there is this huge systemic inflammatory release. All the different cytokines are released into the system, and they can hit any organ system, including the heart. So with the heart, what you end up getting is an inflammation of the heart muscle. So that's myocarditis. You can end up with a stress cardiomyopathy where the heart doesn't squeeze normally. You can end up having a heart attack. And so that can be from plaque rupture associated with having some coronary artery disease and or the clotting disorders that occur with having COVID. And you can block a heart artery with a clot. You can end up with congestive heart failure, cardiogenic shock, and ultimately you can end up with some cardiac arrhythmias that can lead to death. So the treatment options are ongoing and being researched extensively right now. Mostly what we utilize is supportive care. We want to relieve the patient's symptoms, manage their volume status. So if they're dehydrated, give them fluid. If they're in volume overload, try to get that fluid off so that they can breathe easier. We give them oxygen support, and also prone positioning is something that we utilize in the hospital quite significantly. In severe cases, we put patients on dexamethasone, which is an IV steroid treatment to lower the inflammation in the system. We also may need to provide ventilatory support, as well as extracorporeal membrane oxygenation, or ECMO. There are also experimental therapies that are ongoing. St. John's is participating in a lot of different research studies looking at the monoclonal antibody-based therapies, as well as different therapies like remdesivir. There are other ineffective therapies that had been used earlier in the pandemic that are not being used now. They're listed below, but those are not things that we are using currently on our patients. So if we segue into the vaccines for a second, there are two that are out right now. There's the Pfizer and the Moderna. They're both mRNA vaccines, and they both require 2 shots. So the Pfizer one gives you your second shot 3 weeks from your first. Approximately 2 weeks after your second shot, you have a 95% immunity to COVID. The Moderna shot, you get your second shot about 4 weeks after your first, and that will give you the same type of 95% immunity 2 weeks after that second shot. The side effects are considered to be minimal and generally felt to be related to your body's own immune response after you're getting the vaccine. So I get a lot of questions from patients about the vaccine, and one of the primary questions is, can I get COVID from getting the vaccine? And the answer is no. This is not a live virus. There are some people that do feel poorly afterwards, and they may be concerned that they had contracted COVID in that time with fevers, chills, malaise, nausea, vomiting. Generally, those symptoms go away within 24 hours. And clearly, if you had COVID, the symptoms don't go away within 24 hours. Additionally, I have some patients that are concerned about this mRNA technology, since it is the first vaccine using this technology. It is really not new technology. It's something that they have been working on for over 3 decades now. And interestingly, there was a lot of work with SARS and the MERS viruses back in 2006, but the vaccines were ultimately not completed at that time because they lost any financial support. So the irons were already in the fire as it relates to the mRNA vaccine. Was very interesting because this couple that are featured in Time magazine started the BioNTech company, and as soon as they were able to genetically sequence the virus, they were able to create a vaccine, partner with Pfizer back in March, and start animal trials as early as March, looking at the Pfizer vaccine using this mRNA technology. What is very interesting about this is to know that this is something that from a company that they have developed that was using this technology to combat cancer treatments, they can also use it for viral infections as well. This is similar technology that they're looking at for the Zika virus, Ebola, influenza, and also cancer therapies such as melanoma. So how much protection do you need after you get vaccinated? Well, this is a hot area of research because we are not sure. So once you're vaccinated, the concerns are that you will still be able to transmit the virus to other people that are not protected. So the mantra at this time is to still wear your mask, still be as careful as you've been, but hopefully you will be protected against getting COVID, at least at a 95% likelihood. The other issue associated with this is there are talks about how long the immunity will last in your system, and the concept of having a repeat vaccine exists. It may be something similar to the flu shot, or something that you'll need to maintain adequate titers of your COVID antibodies within your system, and you may need to have a redo shot at some point. So in conclusion, COVID is a deadly disease, but it is even worse for our heart disease patients. We have been privy to the first vaccine of its kind, this mRNA vaccine, but it is not new technology. It's something that's been around for quite some time. And once you are vaccinated, you still need to stay safe and protect your family and your loved ones. So that is the end of my talk. I hope you learned a little something from these 5 cases today, and hopefully you'll have some take-home points so that you can be forever young and ask good questions when you go to the doctor's office. From the bottom of our hearts, we thank you so much for supporting our Women's Heart Symposium over the years. We cannot thank you enough for being part of today's activity. Thank you so much for watching this talk. We received some great comments in the Q&A box throughout that I will be sure to get to during our live Q&A session. But now might be a great time to break open your gift box. And we ask you to pull out your green tea as well as your Forever Young tumbler. Since this next talk is going to be something where you're going to want to sit back and relax and enjoy our keynote speaker, Dr. Joanne Manson. Dr. Manson comes to us from Harvard Medical School, and she has published extensively in the field of women's health. She is the chief of the Division of Preventative Medicine at Brigham and Women's Hospital and has received many nationally recognized awards from the American Heart Association, the National Academy of Medicine, and the Association of American Physicians. Dr. Manson is the principal investigator for one of the most important components of the Women's Heart Initiative called the VITAL trial. We are so lucky to have her presenting information from this very trial for us today, and we'll have about 15 minutes at the end of her talk for a live Q&A. So please make sure to still submit your questions throughout her presentation using the Q&A button at the bottom of your screen. Now, please give a warm virtual welcome to Dr. Manson.
Hello, it's really a privilege to have been invited to participate in this symposium and an honor to give this keynote talk. So I'll be speaking about how vital are vitamin D and omega-3s for heart health. And a brief overview of the talk is to review the rationale and the results of VITAL, a large-scale randomized trial of vitamin D and the marine omega-3 fatty acids in the primary prevention of cardiovascular disease. And I'll briefly discuss cancer as well, but I will focus on cardiovascular disease. I'd like to describe the recent updated meta-analyses of vitamin D, omega-3s, and these health outcomes. I'll also briefly talk about a vitamin D and COVID-19 trial that we've just launched, which you may find of interest. And I'll discuss which patients are more or less likely to benefit from supplementation for prevention, and particularly for prevention of cardiovascular disease. So I'd like to thank the National Institutes of Health for supporting the VITAL trial. VITAL is an investigator-initiated trial. The National Cancer Institute and National Heart, Lung, and Blood Institute are co-sponsors of the trial. We have additional NIH support from other institutes and agencies at NIH. I also would like to thank Pharmd for donating the vitamin D and placebo pills, and Pronova Biopharma of Norway and BASF for donating the omega-3s, which are Omicor fish oil, is known as Leveza in the United States. This is a prescription omega-3 medication. They donated the study pills, the matching placebos, and helped with the calendar packaging for the trial. I'd also like to thank Quest Diagnostics, which measured the serum 25-hydroxy-D, blood levels, the omega-3 index, and other biomarkers at no cost to the trial. For those who want additional information, detailed information about the VITAL study, we do have two parallel publications in New England Journal, one on vitamin D and one on the omega-3s. So this slide shows an overview of the VITAL trial, the design. We had more than 25,000 US men and women in the study nationwide. It's a primary prevention trial, usual risk. Most of the previous trials, at least of omega-3s, have been secondary prevention or high risk study populations. We had the goal of studying primary prevention, a more usual risk population. This is a 2x2 factorial design, meaning that we can look at the independent as well as the joint effect of the two interventions. The vitamin D was 2,000 IUs a day compared to placebo, and then each group is further randomized to the omega-3s, EPA, DHA, 1 gram a day at about a 1.2 to 1 ratio. versus a placebo. So we actually have 4 study groups. The median treatment period for the trial was 5.3 years. We had a goal to have racial ethnic diversity, and we were very pleased to have more than 5,100 African Americans in the study, which I'll mention further. And we also had blood collections, nearly 17,000 at baseline, and follow-up in about 6,000 participants. The specific aims of VITAL were to test whether vitamin D and or the omega-3 fatty acids each individually reduce the risk of major cardiovascular events, a composite of MI, stroke, and cardiovascular death, or the parallel endpoint, primary endpoint of total invasive cancer. Our secondary aims were to test whether these agents lowered the risk of individual endpoints of MI, stroke, CVD death, as well as an expanded composite primary that included coronary revascularization, PCI, and CABG. We also were interested in testing whether the agents lowered risk of site-specific cancer and total cancer mortality, and to assess key subgroups, including by age, sex, race, ethnicity, and nutrient status at baseline. Now, I'm going to begin with the omega-3s, the findings for omega-3s, because these are actually a little more straightforward than the results for vitamin D. So as you all know, the omega-3s have been postulated to have cardiovascular benefits through a number of pathways. Many of these pathways do involve decreasing inflammation, but also, especially with higher dose omega-3s, there's reduction in triglycerides, potentially effects on nitric oxide induced endothelial relaxation, decrease in ventricular cardiac arrhythmias, and as I mentioned, decreased inflammation, potential effects on decreasing thrombosis, blood pressure, maybe even on heart failure, and decreasing plaque progression and increasing plaque stability. So a number of mechanisms through which the marine omega-3s, EPA, DHA may reduce cardiovascular risk. Now, why were omega-3s even postulated to be of cardiovascular benefit? Well, some of the earliest data was ecological, data from the Greenland Inuits, the Alaskan Eskimos, other groups suggested that there were lower rates of cardiovascular disease in those populations. There actually has been some controversy about those issues more recently, but meta-analyses of cohort studies were done, and they suggested that people in these cohort studies who had fish frequently, such as at least 5 times per week versus less than once per month, had a substantially nearly 40% lower risk for fatal CHD. Also, there was a suggestion from the observational studies that there was a reduction in the risk of stroke. So overall, there were observational findings suggesting benefits for both CVD and stroke. As we began to see results of meta-analyses emerge, it became clearer, and this was even after the VITAL trial had started, that the results for coronary events seemed to be stronger than for stroke. That in an early meta-analysis, this one was published in 2012, there was a suggestion of a significant reduction in cardiac death and signals for reduction in sudden death and myocardial infarction. However, stroke was really not reduced by these in these earlier trials of omega-3s, where the doses were generally only about 1 gram a day. And these tended to be high-risk populations. As time went on and more patients were being treated with statins and other medications, the meta-analyses of the omega-3s became even less supportive of benefit. Now, why did we see, why did we decide to to test 1 gram a day of the omega-3s or 840 milligrams of EPA DHA in this ratio of 1.2 to 1. Well, we thought that at the time VITAL was getting started in around 2009, 2010, when we were beginning recruitment, that this dose would represent the best balance of efficacy and safety in primary prevention. We wanted to test a dose that had been shown in previous trials, such as JC trial and some of the other secondary prevention trials, to reduce cardiovascular events, but not so high that it would lead to bleeding or other adverse events. Also, in terms of current public health recommendations for primary prevention, the guidelines were suggesting about 250 to 500 milligrams a day, or about 2 servings of fish per week was recommended, and for secondary prevention, about 1 gram a day. So this seemed to fit in well with the health recommendations, but the higher amount than was currently recommended for primary prevention. And also the dose is more than 5 times higher than average US intake of EPA and DHA. In the VITAL trial, this slide shows our baseline characteristics. We had a mean age of 67. We were very pleased that at least half, nearly 51% of the study population included women. And we had racial ethnic diversity with, as I mentioned, more than 5,100 African Americans, which was a little over 20% of the study population. We also had other racial ethnic groups represented. And the prevalence of other risk factors, the current smoking, hypertension, high cholesterol, diabetes, was fairly typical of what you would expect with a midlife to older primary prevention study population among volunteers for a randomized trial. Our follow-up rates and treatment compliance were very good in VITAL. Our mean follow-up rates over an average of 5.3 years. We had more than 93% follow-up for morbidity, more than 98% follow-up for mortality. Our study pill adherence over this fairly lengthy 5.3 year period was also quite good. A mean of greater than 83% taking their study pills. And this was borne out by the biomarker studies, which showed that we had substantial increases in the plasma omega-3 index, more than a 50% increase with the N3s versus virtually no change in the placebo group. And for the serum 25-hydroxy-D, we had about a 40% increase in the level in the vitamin D, active vitamin D taker group. This is in the overall group, not limited to compliers, versus about 2% change with placebo. This slide now shows our main results for the omega-3s and cardiovascular disease. The top half of the slide shows the pre-specified primary and secondary endpoints, and the bottom half shows some additional pre-specified coronary endpoints, but they were not primary or secondary endpoints. Overall, what you can see is that we had a small but not statistically significant reduction in major CVD events, the MI, stroke, CVD mortality, and it was 0.92. The confidence interval included 1. However, for total MI, we had a 28% reduction, and the confidence interval, this was a significant reduction, 0.72, and our nominal p-value was 0.003, and it did stand up to Bonferroni correction. However, we had no reduction in stroke. And as a result, we had no reduction in the composite endpoints that included stroke, such as CVD mortality, which was both coronary and stroke mortality, was not significantly reduced. And our expanded composite, that included major CVD events as well as coronary revascularization was again a small but not statistically significant reduction. Interestingly, when we looked at other coronary events, we did see a significant reduction in PCI, and we saw no reduction in CABG, which was more often being done as an elective procedure. We had more PCIs than CABGs in the trial. Fatal MI were small numbers, but it was significantly reduced. CHD death was in the direction of risk reduction. And for total CHD, which included MI, coronary revascularization, and CHD death, we did see with this 1 gram a day, a 17% reduction with confidence intervals that excluded 0.83. This slide may be a little difficult to see, but it shows for major CVD events, the active treatment group compared to the placebo group, which is the lighter graph. They started to diverge at about 2 years, 2.5 years, and there was this apparently small reduction in risk for major CVD events. But where we saw the real difference was for total MI, and the curves began to diverge after about 1 year, 1.5 years, and they continued to be separated over time. You know, as I mentioned, this hazard ratio is 0.72, and maybe even a little more divergence over time. So for major CVD events, we did not have a significant finding, but for total MI, as I mentioned, the nominal p-value 0.003 and Bonferroni adjusted p-value was 0.015. We had several subgroups that were of interest to look at, and they had been pre-specified, such as by nutrient status at baseline. For major CVD events, it was quite interesting to us that the group that was below the median intake of fish consumption, which was less than 1.5 servings of fish per week, they did have a 19% significant reduction in the primary endpoint of major CVD events. And the group that was already getting the median intake, at least 1.5 servings per week of fish, they had no reduction. This was a borderline significant interaction p-value. We did not see significant interactions by other factors. So it really seemed that nutrient status was a very major factor for the endpoint, our primary endpoint of major CVD events in determining who benefited and who didn't. So those with low fish consumption, fish being the most common dietary source of the marine omega-3s. Now, for total MI, where we had seen this benefit, we were interested in seeing whether there were risk reductions in certain subgroups. So again, we looked at fish consumption, and we saw a greater benefit of reduced risk of MI in those who had low fish consumption below the median. It was 0.60 or 40% lower risk versus a very modest reduction in those who had, this is in total MI, versus those who were above the median. And that was a significant interaction, but borderline. Where we did see really major interaction for total MI was by race. And we saw among African Americans, there was a surprisingly large risk reduction. We had a hazard ratio of 0.23. This needs to be replicated because all of the other omega-3 trials have been predominantly white populations. They've had very, very small numbers of African Americans and Blacks. So we do feel this needs to be replicated, but it was a very encouraging, promising finding of a substantial reduction in MI among African Americans, much less of a reduction among non-Hispanic whites, or other groups, the confidence intervals were wide. We also saw that in those who had more risk factors for cardiovascular disease, this is in the overall study population, those who, for example, had 2 or more standard traditional risk factors had a hazard ratio of 0.57 for MI, so they did show evidence of benefit. Those who had 1 standard risk factor had 0.75, that was hazard ratio, not quite significant. If they had no risk factors, there was no sign of risk reduction. We didn't see interactions by age, sex, statin use, aspirin use, or baseline triglyceride levels. So these were really the factors: nutrient status at baseline, race, ethnicity, with African Americans doing much better, and those who had 2 or more risk factors had the risk reduction for MI. Now, you're all familiar with the REDUCE-IT trial and icosapent ethyl trial. I just want to point out this was a much higher dose, and it was EPA only. It was 4 grams a day. And as you well know, there was a significant finding for the primary endpoint, which included CVD death, MI, stroke, coronary revascularization, unstable angina, very strong result. And it's believe that EPA may be more beneficial for coronary disease and even for total cardiovascular disease than DHA, and that may be one of the reasons, as well as a much higher dose of icosapent ethyl that was tested. But I'm going to come back to this in the meta-analysis. So effects on biomarkers, we saw a modest reduction in triglycerides with the 1 gram a day of Omicor or Leveza, whereas in REDUCE-IT, there was about a 20% reduction in triglycerides. The REDUCE-IT trial saw a reduction in LDL cholesterol, but we did not have a reduction in LDL with a combination of EPA plus DHA. And the high sensitivity CRP was decreased in REDUCE-IT, but we saw a reduction only among those who had the low fish consumption, and that was the group that benefited in terms of MI and major CVD events. Now, we've done a meta-analysis to look at the results of VITAL in the context of other trials of omega-3s, and we have done these analyses with and without, including REDUCE-IT. And more recently, as you know, the STRENGTH trial, which was testing a different formulation of EPA plus DHA, had no clear signal for CVD benefit, even though it was 4 grams a day. So clearly formulation is going to be a major issue. But in this meta-analysis that we published in the Journal of the AHA, we saw that if you take all of the trials that lasted at least a year and that were done prior to the STRENGTH trial, including VITAL and REDUCE-IT, the relative risk for MI, this is for myocardial infarction, was 0.92. It was a significant risk reduction. Most of these trials were just one gram a day or relatively modest doses. And if you include REDUCE-IT, the 4 grams a day of EPA, the relative risk was 0.88. So either way, there was a significant reduction in myocardial infarction with the omega-3s. And this meta-analysis included 13 trials, more than 127,000 participants. Now, interestingly, when you look at stroke, this was the problem in terms of our major composite endpoint, a CVD composite not being reduced, is we did not see a reduction in stroke. And also the randomized trials of omega-3s, except for REDUCE-IT, have not shown a reduction in stroke. In fact, in the meta-analysis, the relative risk for stroke was 1.05. REDUCE-IT did see about a 25 to 30% reduction in stroke. So that's definitely an outlier. And I think this needs more research to understand how we can reduce the risk of stroke with omega-3s. Maybe it's just going to require EPA only and require much higher doses. But this is a difference. The stroke results are quite different in meta-analysis looking at the earlier trials versus the REDUCE-IT trial results. Now, we also did a dose response gradient study looking at all these different trials. And for every one gram increase or 1,000 milligram increase, we saw about a 9% reduction in risk of total CVD. We included REDUCE-IT in this analysis because we did not see significant heterogeneity across trials, but a lot of this, of course, at the high dose level is driven by REDUCE-IT. However, there's already a suggestion, even at lower doses, of a dose response gradient going on. I'm going to shift gears now and move to vitamin D. As you know, we have both endogenous, exogenous sources of vitamin D. We synthesize vitamin D in the skin with UVB exposure. We also can get vitamin D from foods such as fortified dairy products, and it's within fatty fish, and also we can get it from supplements, vitamin D supplements. What are mechanisms through which vitamin D may lower cancer and cardiovascular risk? We know that from animal studies and small clinical studies and cell culture studies, there's quite a bit of evidence for vitamin D having effects on, or at least theoretical effects on cancer prevention, inhibiting cell proliferation, inducing apoptosis, cell differentiation, inhibiting angiogenesis and metastasis. There are effects on immune modulation and inhibiting inflammation. This is something we're trying to leverage in testing vitamin D against COVID currently. Also, there have been postulated effects on blood pressure, glucose tolerance, and inhibiting vascular smooth muscle proliferation, but this has really been controversial in terms of CVD prevention. Now, I know that many of you have seen repeated studies suggesting that low vitamin D blood levels, low 25-hydroxy-D, with the 25-hydroxy-D being probably the best marker of the vitamin D status, that this is often linked to an increased risk of cardiovascular disease, cancer, and type 2 diabetes. But I just want to caution that correlation does not prove causation, and there are many other reasons that a low blood level of vitamin D might be correlated with an increased risk of these conditions, such as poor general nutrition, low dietary intake of vitamin D. Poor nutrition itself is linked to chronic diseases. Obesity is associated with low 25D level, but we know that, that the vitamin D gets sequestered in the fat tissue. However, obesity is known to be a risk factor for these chronic diseases. We also know that low physical activity levels associated with less time outdoors, being physically active outdoors, less sun exposure, but physical activity itself is very protective against these chronic diseases. In addition, chronic diseases serve as can lower and consume vitamin D as almost a reverse acute phase reactant. And so there can be a correlation in that regard as well. So these associations do not prove causation, which is why it's so important to do randomized clinical trials. Now, what does the Institute of Medicine or the National Academy of Medicine recommend in terms of dietary intake of vitamin D? For ages 9 to 70, 600 IUs a day is recommended for bone health, so not very much. We're testing 2,000 IUs a day in Vital. For age 70 and older, 800 IUs a day is recommended. And the RDA is defined as covering the needs of at least 97.5% of the population in the absence of sun exposure. So for bone health, we need actually very little vitamin D, and the tolerable upper intake level was set at 4,000, and that's the level above which there's some risk of adverse events. Of course, there's some controversy about that and some evidence that getting higher than 4,000, even to 10,000, probably isn't really associated with toxicity. So really anywhere in between the RDA and the tolerable upper intake level would be reasonable for intake of vitamin D. However, there's much more research at the lower end of this range in terms of safety outcomes. The recommended 25-hydroxy-D level by the IOM was at least 20 nanograms per mil or 50 nanomoles per liter. There's a 2.5 to 1 ratio between nanomoles and nanograms here. And what was set as the tolerable upper intake blood level was 50 nanograms or 125 nanomoles of 25-hydroxy-D. But again, there's a lot of controversy and the view that these levels may have been set too low. So we wanted to test a higher dose that would lead to higher blood levels of vitamin D. Now, in the VITAL trial, where our achieved blood level was much closer to 40 nanograms and above 100 nanomoles per liter, what we saw, I'm going to start with cancer. We saw for total invasive cancer, not a significant reduction, but for cancer death, we started to see a signal that there might be a reduction there. It was really neutral for all-cause mortality. We had pre-specified that we wanted to take into account latency period, excluding the first 1 and 2 years. And we did see for cancer death, excluding either 1 or 2 years, I'm showing here the results for 2 years of exclusion, we did see a significant reduction in cancer death. And I'm going to show you how the Kaplan-Meier curves looked. For total cancer incidence, it really wasn't until about 4 years that we started to see a separation of the curves with a little lower risk in the active treatment group. And this would be expected with an outcome like cancer where there is a long latency period. For total cancer mortality, again, it was nearly 3.5, 4 years before the curves began to separate, but then we saw the separation of the curves. Excluding the first 2 years, as I mentioned, the hazard ratio is 0.75, and that was a nominal p-value of 0.024. Now, looking at subgroups that might be of interest for cancer, we saw that there was a signal for a greater risk reduction in total invasive cancer among African Americans, but it didn't quite reach statistical significance. It was 0.77 borderline interaction by race ethnicity. However, when we looked at body mass index, we did see that even for total incident cancer, total invasive cancer, there was a signal here that those who were at a healthy weight, a BMI less than 25, did have a risk reduction. Higher BMI groups did not have a risk reduction with vitamin D. And this was strongly statistically significant interaction, a 0.002. So we want to explore this further, and an interaction by BMI has been suggested for other endpoints as well, including diabetes, which I'll talk about in a few minutes. But we did not see a modifying effect of age or sex in these findings. We also saw a modifying effect of body mass index for cancer mortality. And for BMI healthy weight, less than 25 BMI, we saw it had a hazard ratio of cancer mortality that was 0.58, and that was quite significant, but no reduction for other BMI groups. And the p-value for interaction by BMI was 0.02. We did a meta-analysis that included the 5 trials large enough to look at cancer mortality as well as total cancer incidence. There's very little going on with total cancer incidence, but for cancer mortality, there is evidence from almost all of the trials, except for a New Zealand trial that used bolus dosing of vitamin D, that there is some reduction in a risk of cancer mortality. and it was a significant in the meta-analysis, 0.87 with a P of 0.005. Now, why would vitamin D reduce cancer mortality but not cancer incidence? It may be because of effects of vitamin D on tumor biology, making tumors less invasive, less likely to metastasize once they're formed. And there is some evidence of that from the laboratory research and the animal studies. Now, I want to move on to CVD and what our results were for vitamin D and CVD. But before I do that, I want to show you some observational data. The relationship between serum 25D and some health outcomes in a meta-analysis of observational studies. I previously showed you meta-analyses of randomized trials. But in observational studies, what has been shown is that for cancer, particularly colorectal cancer, there is this gradual reduction in risk as you get to higher blood levels, like as you get to 40 or 50 nanograms, you begin to see a lower risk than if you start out relatively low. Whereas with cardiovascular disease, even the observational studies suggest that you need very little vitamin D. You just need to be around 20 nanograms of vitamin D and you're already at the nadir of the curve. And then it really plateaus out, maybe even a small uptick here. So there may be a difference in vitamin D requirements, just as bone health doesn't require much, but there's a suggestion that cancer mortality and cancer may, as you get to higher levels of vitamin D, you may see some benefits. It's possible that for vitamin D, you need very little. And this is actually borne out by seeing no risk reduction with vitamin D supplementation for our cardiovascular endpoints. So for major CVD events, 0.97, confidence interval nowhere near suggestive of benefit, also total MI, stroke, CVD mortality, and our expanded endpoint. And for CVD, we did not see a modifying effect of age, sex, body mass index, or baseline 25D. Because almost all of our participants, a very large percentage, were already close to 20 nanograms where they had higher blood levels. They were not profoundly vitamin D deficient. We did not see any benefit of supplementation for cardiovascular endpoints. So this doesn't mean that vitamin D isn't important for cardiovascular health. It just suggests that the amount of vitamin D needed, as for bone health, may be relatively modest for coronary cardiovascular health. But more research will be very helpful. There is some evidence that body mass index modifies results for type 2 diabetes. I want to show you the D2D trial that was published in New England Journal almost 2 years ago. The overall results, this was a large trial, tested 4,000 IUs a day for 2.5 years. The overall hazard ratio for type 2 diabetes with vitamin D, high dose vitamin D, was 0.88. But you may be thinking, well, the reason we're seeing BMI as effect modifiers, you just need higher doses of vitamin D in people who have higher BMI. But in the D2D trial, they tested 4,000 IUs a day, and the benefit was only in those who were not in an obese category of BMI. So if the BMI was below 30, the hazard ratio was 0.71. with 4,000 IUs a day, but there was really no risk reduction for those with BMI 30 and higher. Whether this is due to almost a type of vitamin D resistance that can occur, maybe it's at the receptor level or the reduced bioactivity of vitamin D in the setting of obesity. This could be related to more inflammation that goes on in that setting. It isn't really clear, but this needs much, it needs further research. This is a very important issue to understand so that vitamin D ultimately can become an effective intervention for people of all BMIs. Right now, it really seems to be much more effective for those in healthy weight categories. Now, We did a meta-analysis. We participated in meta-analysis of randomized trials of vitamin D and type 2 diabetes. And again, if you look at 9 randomized trials, more than 43,000 participants in all, you'd see this modifying effect by BMI. If the BMI is less than 30, 0.68 for diabetes risk, type 2 diabetes risk, nothing going on with higher BMIs, interaction there's interaction by BMI. Another meta-analysis, this was published in Journal of Clinical Endo and Metabolism. Another one was published in Diabetes Care, showed the same thing, all of the benefit for vitamin D in terms of type 2 diabetes was in those who had a BMI that was in the non-obese range, and there was a signal for interaction. Just getting back to meta-analyses, but this time for cardiovascular disease, we collaborated on a meta-analysis that included 21 trials, more than 83,000 participants. The results for MI could not have been more null. The hazard ratio is 1.00, confidence interval, really, there's no suggestion of benefit. Nearly every single randomized trial of vitamin D showed no benefit for cardiovascular disease. And again, don't view this as meaning a vitamin D is an essential for cardiovascular health, and that it's important to avoid vitamin D deficiency in terms of cardiovascular disease, but there does not seem to be a benefit of large doses of supplementation. What about side effects and adverse events that have been identified? Well, we were very pleased to see that in VITAL, there were no significant side effects with either agent. These are relatively moderate doses, 1 gram a day, omega-3s, 2,000 IUs of vitamin D. We did not see significant side effects. We did not see an increased risk of hypercalcemia with vitamin D. We saw no increased risk of bleeding with the omega-3s, and we saw no increase in GI symptoms with either agent. So we had relative safety of both supplements over 5.3 years. We have several other studies that are in the pipeline that will be published very soon, looking at other outcomes, including cognitive function. We're looking at diabetes, hypertension, heart failure, many of the bone health, infections, mood disorders. We're going to be publishing these results over the next several months. So in conclusion, neither the omega-3s 1 gram a day nor vitamin D 2,000 IUs a day significantly reduced the primary endpoints in VITAL of major CVD events or total invasive cancer. However, the omega-3s did significantly reduce total myocardial infarction, which was a pre-specified secondary endpoint, reduction of 28%. It was a significant reduction. The greatest reduction was in those with low fish intake and in African Americans. Angioplasty, fatal MI, total CHD were also reduced, but we saw no reduction in stroke, which obscured any benefit for the primary composite endpoint. Now, with vitamin D, we did see a reduction in total cancer mortality in analyses that accounted for latency. And in the REDUCE-IT trial, as you know, icosapent ethyl, 4 grams a day, it was a very strongly significant finding, suggesting that dose and formulation are very important. Our updated meta-analysis showed a decrease in CHD and in CVD with omega-3s with a dose response gradient, with EPA decreasing risk more than EHA. What about the clinical and public health implications? Well, I'm going to talk about primarily primary prevention. I think icosapent ethyl is now being recommended by many professional societies for secondary prevention and high-risk populations. But in primary prevention, usual risk populations, what can we say? Well, we can encourage fish consumption, at least 2 servings per week. And even if there isn't a clear benefit from the omega-3s in the fish will replace less healthful foods such as red meat, processed foods, And so that has been associated with lower cardiovascular risk in many types of studies. If people have low fish consumption, they don't like fish, they're allergic, or they are vegetarian, vegan. In the latter circumstance, there are algae-based supplements. If someone doesn't like fish, they may actually benefit from fish, having a fish oil supplement or omega-3 supplement, especially if they have risk factors for cardiovascular disease. And I think with, if we can corroborate the findings in African Americans and Blacks, that may be another group where there will be a real benefit. People who are allergic to fish, however, would not be able to take the fish oil supplements. So it would have to be an algae-based or some other source. For vitamin D, we didn't really see findings that would lead to a clear change from the IOM National Academy of Medicine 2011 guidelines for vitamin D. We saw no clear indications to use vitamin D for cardiovascular prevention, aside from everyone trying to avoid vitamin D deficiency. We need more research on cancer, but there are some promising findings for cancer mortality. We would recommend individualized clinical decision-making for whom to screen for vitamin D deficiency, obviously based on risk factors and bone health. People who have bone health problems, malabsorption conditions, or other high-risk conditions where screening and supplementation would be a benefit. But we do discourage megadosing, because very, very high doses, such as more than 10,000 IUs a day for extended periods, may be associated with risks from vitamin D. Stay tuned for our extended follow-up findings and ancillary study results in the next 3 to 6 months. And we're also hoping to be able to do additional research, and for other groups to do additional research on high-dose EPA, especially in African Americans. I want to mention briefly and acknowledge my colleagues on a trial of vitamin D for COVID. We call this the VIVID trial. It's a pragmatic, cluster randomized design of high-dose vitamin D, at least 10,000 IUs for 2 days and 3,200 IUs for 4 weeks, trying to reduce severity of COVID, severity of symptoms, need for hospitalization or medical attention, and also for prophylaxis against contracting the infection among household contacts. So my final slide, I just want to express my gratitude to the more than 25,000 vital participants throughout the United States, and all of the investigators and staff who have been involved with the VITAL trial. On this slide, you can see photos of VITAL co-authors. Special thanks to Nancy Cook, Ayman Lee, Sammy Amora, David Gordon, Denise Agostino, Walter Willett, and Julie Buring. And really tremendous effort over at this point. This has been 9 to 10 year effort. And thank you so much for your attention. I look forward to your questions. Thank you.
Well, thanks so much to our speakers for that powerful and provocative data. I'm going to jump right into some fabulous questions from our audience, starting with a lighthearted one. Dr. Manson, if we do put patients on fish oil, suggesting that the data support it, and we put all of our patients on it, are there enough fish on the planet to permit this?
Well, I think that's actually a very important question. And I think this has to be sustainable. There are ways to make this, to having fish oil be more sustainable for a large segment of the population. However, I do think more research is needed on the algae-based omega-3s. And there's some research that is going on right now. There's a trial called Do Health that is testing algae-based N3s. And also we need more research on alpha-linolenic acid, which is not a marine omega-3, but is a plant-based omega-3. So I think there are at least 3 different directions that we should be going in terms of providing more data on the relationship between omega-3s and health, as well as making omega-3s, providing omega-3s to the population in a more sustainable way. I think that we do need to think about really sustainable farming and, fish farming, as well as avoiding catching of fish and protecting fish in their natural environments. We also need more research on the algae-based fish oil and the alpha-linoleic acid N3s.
Great, thank you. And so your presentation suggests that there may not be as widespread benefit as we initially thought, but there are some patients who are very likely to benefit from omega-3 supplementation, particularly if they've had a heart attack before, have low fish intake. For the patients in whom you do recommend supplementation, how many milligrams do you suggest?
So in secondary prevention, I think the Reduce It trial is very compelling. So I think it's going in that direction in terms of using icosapent ethyl for the patients who already have a history of a cardiovascular event or have high triglycerides, diabetes, multiple risk factors for cardiovascular disease, and meet the criteria for participation in the Reduce It trial. 25% reduction in their primary endpoint, and it had a very reasonable benefit risk balance. I would like to see actually a replication trial of icosapent ethyl and more research in high risk primary prevention with icosapent ethyl with Vascepa. But I think that's the direction it's going in terms of secondary prevention and really high risk patients. For primary prevention, which was the goal of the VITAL trial, I think that we don't really have evidence for doses higher than 1 gram a day at this point. We need more research on the higher doses. But I think the VITAL trial, which is the largest trial in primary prevention, there's very, very little research in primary prevention, the omega-3s, that the groups that benefited were those with low nutrient status, those who had low fish consumption, and then we need more work on studying at the African-American Black populations to see if that finding can be replicated. So I would say 1 gram a day, and I would say either EPA only or a combination of EPA plus DHA with a slightly higher amount of EPA, such as in the Leveza, it's 1.2 to 1 ratio. Of course, the question always comes up, can you get this over the counter? And if you are going to use over-the-counter fish oil supplements, I would strongly recommend that you look for the various labels indicating quality control, auditing, such as a USP label, such as consumerlab.com or NSF. It needs to say something indicating that there is quality control assurance.
Thank you. And is a question from the audience, is there any evidence that omega-3 supplements can act in any sense as an aspirin substitute in terms of blood thinning, or has that been pretty clearly disproven?
Well, first we did look at whether there's a modifying effect of taking aspirin and whether the two should be avoided. In the VITAL trial, we did not see any adverse effects in those who were taking aspirin, which was close to 30% of the population. So I don't think omega-3s necessarily have to be avoided in someone taking a low dose aspirin. I don't consider it a substitute for aspirin, though. I think in secondary prevention, the guidelines are clear for aspirin. And then, I think the Reduce It trial results need to be looked at very carefully in terms of which patients should also be given icosapent ethyl. In high-risk primary prevention, as you know, there's a lot of controversy about the use of aspirin. Things have really changed. And there may be now more interest in the potential for omega-3s to take the place of aspirin in a high-risk primary prevention population. I think that's actually a reasonable hypothesis, and with more research that may in fact be a very reasonable strategy to try to use more EPA or higher doses of the marine N3s instead of aspirin in primary prevention, because the balance of benefits and risks in primary prevention using aspirin are not optimal.
And do you see a consistent effect on the omega-3 supplementation in terms of blood sugar?
In terms of blood sugar, most of the trials have shown either neutral results or maybe a small increase in blood sugar, but not clearly clinically significant. And I think there's going to be more research on that soon in terms of the icosapent ethyl. In terms of Vital, we're going to be publishing, we're still in the process of completing all of the adjudication of the diabetes cases in the study, and we will be reporting hopefully within 3 to 6 months on both the vitamin D and the omega-3 results for diabetes, type 2 diabetes in Vital.
Okay, great. And then any measurable effects on other hormones?
Of the omega-3s?
Yeah.
Which types of hormones? Do you mean like thyroid, or estrogen?
I think the question is referring to estrogen, progesterone.
Yeah, we didn't see clear sex differences, and we haven't seen that hormone therapy uses an effect modifier, though you know that in current years, there's much lower prevalence of use of estrogen therapy than in the past. So Vital, as a contemporary trial, really did not have a large number of women on estrogen therapy. So I don't think we have a definitive answer about interaction there.
Okay, thank you. And what do you say to patients who are worried about mercury levels?
There's zero mercury in the prescription drug products. So Soliveza and the Omicor that we tested was very thoroughly vetted for any heavy metals and mercury, and did very well. It was very, very high quality assurance. But these are very reasonable questions to be asking about over-the-counter supplements and the quality control that is in place. And it varies quite a bit with over-the-counter supplements. But do look for the USP seal. Do look for other evidence of quality control audit going on for over-the-counter supplements.
And then on vitamin D, why do you think that body mass index is such a powerful predictor of the vitamin D effect?
So really terrific question. And we're totally intrigued by the effect modification by body mass index. It actually had not really been seen or highlighted prior to Vital, but we're seeing it in Vital for a number of endpoints. And then when the D2D trial for diabetes showed such a strong effect modification, really began to look much more seriously at this. So right now we're doing some studies looking at whether there's failure to suppress parathyroid hormone, whether there's a difference in the PTH response to vitamin D supplementation. We are seeing a signal for that, which would suggest that there's less bioactivity of the vitamin D supplement. We're looking at free vitamin D, free 25 hydroxy vitamin D, a relatively new assay that measures the free marker. And we're seeing if there's any difference according to body mass index. But we are exploring this in great detail. And we're also planning an additional trial to do more of a dose ranging study to understand how much of this is dose related. Doesn't seem to be dose related, with no effect of 4,000 IUs a day in D2D trial in those with BMI above 30. But this definitely needs to be explored, because I think it may end up providing new insights into how to make vitamin D supplementation of greater benefit to the population and of benefit to people across BMI categories.
And And how much vitamin D is obtained from sun exposure?
From sun, well, it varies a lot by the amount of sun exposure you have, and of course, sunblock. You wearing sunscreen tremendously decreases the amount of UVB, the UVB effect on synthesizing a vitamin D in the skin. So if you have totally unprotected skin and you go out for 15 to 20 minutes with, let's say, your legs and your arms, totally don't really do wear sunscreen on your face and the other parts of the body that may be particularly susceptible to the aging effects of the sun. But if you have your arms and your legs exposed for 15 to 20 days, you will synthesize close to 5,000 IUs a day, maybe even closer to 10,000 IUs a day, with totally unprotected skin. Okay. But the dermatologists do not recommend that. I'll just say they have a lot of concerns about that recommendation. And, incidental sun exposure is very much encouraged, getting out, being physically active, and you will get some incidental sun exposure, but actually going out and sunbathing and having unprotected skin with a continuous exposure for even 20 minutes. I think most of the dermatologists are saying they don't recommend that, and they would instead recommend taking supplements of vitamin D.
Okay, great. Thank you very much. This question and answer session went very quickly, but there's a lot of other questions that we'll try to address in the chat. Thank you so much.
Oh, thank you.
Hi, I'm Debbie Allen, and I'm giving a big shout out to the Women's Heart Symposium. I know you're doing a whole thing with a topic of how to live forever. I'm gonna live forever. Well, we might not live forever, but we can always improve the quality of our life if we take active control over our health care. So good luck to you guys. Mwah. Bye.
Welcome back, everyone. As many of you know, our late partner Bill Cabine was on the executive board of Camp Del Corazon. This is a wonderful charity we've partnered with this year to give kids with congenital heart disease a safe reprieve. Our donation will help a full bunk of kids enjoy year-long activities under the guidance of well-trained staff so that they can enjoy themselves in a safe environment. Thank you, Camp Del Corazon, for all that you do, and thank you for helping us to be part of this fantastic donation. Our next speaker is Alyssa Billingsley, Pharmd. She's the Director of Program Development at GoodRx. GoodRx is a company we love as physicians because it helps our patients get their drugs at fair prices. With over a decade of experience in the pharmaceutical industry, she speaks on topics including pharmacovigilance, drug development, and even the COVID vaccine. Dr. Billingsley has made it her quest to find out where medications come from so that we can stay safe and forever young. Without further ado, here's Dr. Billingsley.
Hello, everyone. My name is Dr. Alyssa Billingsley, and I am the Director of Strategic Program Development and a pharmacist on the research team at GoodRx. And today I'm going to be presenting on how safe is your medication, the role of the FDA in protecting the public. Okay, so before we go ahead and get started, I'm going to walk through a few objectives to start. So first, I want you to be able to understand the roles and responsibilities of the FDA for ensuring the safety, efficacy, and security of drug products distributed in the United States. So we'll be walking through the different functions of the FDA, starting with the approval of new drugs, monitoring the facilities manufacturing them, and tracking any new adverse events or concerns that come up after approval. Secondly, you'll learn about how drugs are approved for human use, including the differences between new or brand medications and generic approvals. Next, we'll be touching on emergency use authorizations, or EUAs, that are currently in effect during the pandemic and how they differ from the full approval process and why they might be used. Next, I want you to understand why drugs may be recalled or withdrawn from the market and what that means for patients. So I'll actually give a few examples of when that has happened recently. And lastly, you'll learn how the FDA reviews and responds to potential risks and new safety information for drugs. So first, we'll start out with the basics. Most of you are probably familiar with the FDA, but you may not know the full scope of what they do to make sure our medications are safe and effective. So the FDA, or the Food and Drug Administration, is a regulatory agency that regulates a wide range of products. Today we'll be focusing on human drugs, but they also oversee veterinary drugs, cosmetics, foods, medical devices, and other products as well. They also regulate supplements too, but that's under a different set of regulations. And so they do a lot in this respect, but we'll be focusing on 3 roles in particular. The first being reviewing and approving new drugs. And so when we talk about a drug being FDA approved, it's for specific use, dosing, and within certain populations. Next, we'll walk through how they register and inspect facilities. So a big part of drug safety is obviously that the facilities manufacturing the medications are doing so in a way to ensure that they meet strength and potency requirements and they aren't contaminated before they get to you. And lastly, they ensure the safety, efficacy, and security of drugs. So we'll walk through drug recalls, market withdrawals, and safety signals. So first we'll start with reviewing and approving drugs. So first, when a drug is approved, it goes through a new drug application process, or NDA. But before it gets to that point and gets actually tested within humans, there will be some preclinical testing. And a lot of times that will happen in animals. And that is mostly used to determine safety. So how the drug is being absorbed, broken down, and removed or excreted from our bodies. And also most drugs actually don't make it beyond this point. And so assuming, something looks really promising, the drug sponsor may file what's called an investigational new drug application, or an IND. And this is where they show the FDA the results from the animal testing and how they plan to actually test the medication within humans. And so the FDA reviews all this information, and they determine whether or not it's safe to move forward with human trials. And so once we get to that point, the FDA approves the IND application. It goes through clinical trials. We'll focus on phase 1, 2, and 3. So phase 1 is generally in a smaller group of healthy people. And so they're just making sure that the drug is going to be safe and figure out some of the dosing that will be used. Second, phase 2 is generally in a larger group of people with the condition. And so here we're focusing more on efficacy and side effects, since we are looking at the drug within people who have the condition, seeing if it works for that particular condition. And then phase 3 is with an even larger group of people with the conditions, looking at efficacy again, as well as adverse reactions. And we'll touch on this again later in the presentation. But when you have a smaller group of people, some of the more rare side effects or adverse events may not show themselves. And so when you open it up to a larger group of people, some of those things may come to light. And so assuming everything looks good, it appears to be effective to treat the condition, appears to be safe, the drug sponsor will file a new drug application, or an NDA. And this is where they ask the FDA for approval. And so through this, the FDA reviews this information from the animal testing, from the human trials, to see if the benefits outweigh the risks and if the drug is safe and effective for its intended use. So once a new drug is approved, what happens? So the FDA has determined that it's safe and effective for its intended use in a specific condition and population. And so again, most drugs are not tested in certain populations, like children or pregnant people. And so it may not be indicated within those populations. And so, the FDA also approves labeling along with, as part of the drug approval process. And so that labeling actually, lays out how the drug is to be used and how it's approved to be used. So when we talk about drug safety and use the word safe, it doesn't mean that there aren't risks, but there is ongoing monitoring of the drugs after approval, and as well as in the approved labeling. that actually lays out how you can identify these risks and how to manage some of these risks as well. So once a drug is approved, prescribers can use their clinical judgment to prescribe the medication. Sometimes this is done outside of the approved labeling. So like I've said, a lot of medications are approved for use in adults, but not children. And so prescribers may actually choose to use them in children or other populations or for other conditions that weren't approved. And this is called off-label prescribing. And this is perfectly legal and actually very common. 1 in 5 prescriptions written in the US is for an off-label use. Lastly, the brand manufacturer does get some exclusivity to market the medication for a period of time without any sort of generic or lower cost competitors in the market. So there is an incentive to, go through this drug approval process with that respect. So next we'll get into generic medications. So previously, generic medications needed to go through those preclinical and clinical trials like the brands, but the Hatch-Waxman Act of 1984 established this new process called the Abbreviated New Drug Application, or ANDA process, that actually made it a lot easier for generics to get approved. So, prior to this, there weren't a lot of generics out on the market. After this, the generic drug industry boomed and has really brought us to where we are here today, with about 80 to 90% of prescriptions being filled in this country for generic medications. Now, through the ANDA process, companies don't need to repeat the animal and human research, but they do need to show that the drug is therapeutically equivalent to the brand. So this means that it has the same actives, dosage form, strength, and route as the brand, and that it's absorbed similarly in the body and gets to the same targets as the brand drug. And so I've kind of laid out the different parameters that the FDA is looking for whenever an ANDA application is submitted. And so again, same actives, dosage form, strength, and route, has the same time release technology. There may be some variability in the inactive ingredients that are used, or excipients or binders that are used in the medication, but they need to make sure that they are safe and they don't actually change how the drug works in your body. Again, they need to be able to produce the same result as the brand drug, have the same label, that the product has, a good shelf life, so it doesn't, break down quickly, how it's being packaged and put together, that the manufacturer can make the drug correctly and consistently, that the drug is being shipped and stored appropriately, and lastly, making sure that those patents and legal exclusivities that the brand has are expired, and so they are able to manufacture and distribute these generic products. So we'll walk through a few brand versus generic frequently asked questions. So a big question is probably, are generic drugs different from their brand versions? And so, very technically speaking, generic drugs are modeled after their brand versions. So they should work the same way and provide the same clinical benefit. But as I, spoke to earlier, they are not identical, or they may not be identical. And so again, they may have different inactive ingredients, binders, fillers, et cetera, in the way that they're put together. So can there be some variability? Yes, there can. So this tends to be small and not medically important, according to the FDA. But of course, there are some exceptions to that, and we'll get into that here shortly. And so a large study showed that there was about a 3.5% difference in how generic drugs were absorbed by the body compared to the brand. So are there times when you should be taking the brand or may need to? And so yes, there are. The first and probably most obvious reason is that there are no generic versions available. So if a medication is only available as a brand, you really don't have any options there. Secondly, it's a narrow therapeutic index drug. And so this is when small differences may lead to some issues. And so there's a small margin in dosing between the therapeutic and toxic doses. And so these types of drugs include some seizure medications, thyroid medications, and medications used in organ transplant. And lastly, you may just not do as well in the generic version, or you may be allergic to one of those inactive ingredients. And so those are just a few examples of why you may need to take the brand version instead. So what types of drugs are being approved? So let's start by looking at the years 2000 to 2008. So during this time, neurological drugs, so drugs to treat depression, for example, and cancer medications were at the top, followed by cardiovascular drugs and biologics. And then you've got antibiotics and antivirals, and then everything else. So moving forward to the years 2009 to 2017, we do see a shift towards more anti-cancer and biologics, with a decline in cardiovascular and neurological drugs. And also during this time, more new drug applications were actually being submitted as well. And so one of the reasons we saw, this shift happened is that the FDA does offer fast track, breakthrough therapy, priority review, and accelerated approval paths for novel treatments to bring them to people more quickly. So for example, there may be drugs that help meet unmet medical needs or show a significant benefit or over currently available therapies, or offer significant advancements in medical care. And so there is an incentive to move forward with these drugs and get them accessible faster. So the FDA may review portions of the drug application ahead of time. So rather than waiting to the end, they're more involved in the process. They provide intensive guidance through the process. They may cut down the target review time from the standard 10 months or so down to 6 months, or they may approve drugs early to help bring some of these drugs to the market faster. But not all drugs may go through the FDA approval process right away, especially when there is a public health emergency. So we've actually seen this happen during the current pandemic to get people access to treatments, tests, and vaccines more quickly without necessarily being part of a clinical trial in some cases. So in this case, the Secretary of the Department of Health and Human Services can give the FDA the ability to temporarily authorize products during an emergency. So when we talk about some of the diagnostics, drugs, and vaccines used during COVID-19, they are not FDA approved, at least not yet. They can be authorized through what is called an emergency use authorization or an EUA. But when the public health emergency is over and they haven't actually pursued full FDA approval, they can no longer be used. But not just anything can get authorized. So it's not like you can say, hey, I have this new, medication or test or vaccine. I'm just going to start, using it or releasing it into the public. That's not an option, how it works. And so companies do still need to submit information for the FDA to review. And the FDA then makes a decision based on the best available data at the time to determine if benefits outweigh the risks. So these EUAs can be approved, changed, or revoked at any time by the FDA. And we've seen that kind of happen over the course of this time. So for example, there was an EUA for hydroxychloroquine, but when it became apparent that it wasn't as effective for its use, the FDA revoked that EUA. There are some, or actually one in particular, that has since gone on to become FDA approved, that being remdesivir. So next we'll move to registering and inspecting facilities. So an important part of drug safety is ensuring that the manufacturer making the drug meets quality requirements. So this is to make sure that the product that you receive has the right active ingredients and the correct strengths, and that it isn't contaminated with something that could be potentially harmful. So facilities that are manufacturing, repackaging, or relabeling drugs for distribution within the United States need to register with the FDA, and this is renewed annually. They also need to submit a list of their drug products, I believe twice annually as well. And the FDA can inspect these facilities at any time, and they must comply with what is called the Current Good Manufacturing Practices, or CGMPs. And so just to kind of walk through what some of those components are, it's that you document your policies, procedures, and processes and follow them in a way that you operate. Sometimes these facilities may be sourcing ingredients from manufacturers elsewhere. And so they need to make sure they are of good quality, they aren't contaminated. And so if they don't, for example, you can run into problems, which we will touch on here shortly. We also need to make sure that they are manufacturing a good quality product, and that they have robust testing as well, because a big part of CGMPs is product testing, both throughout the manufacturing process and of the final product, to detect any quality deviations. And this is to catch a lot of the issues before they actually make it to the consumer. And lastly, being able to detect and investigate any quality deviations that are found. And so this really goes hand in hand with product testing, ensuring that they're able to identify these issues and investigate what may be causing them. So where are these facilities located? So in 2018, it was estimated that 60% of drug manufacturers providing drugs for the US were actually located overseas, which constitute about 40% of finished drugs and 80% of active ingredients. And so most of these facilities are located in China and India. Also, some people are proposing that we import finished drugs from Canada. So as opposed to having FDA registered facilities in other countries, but actually importing finished drugs from Canada as a way to reduce drug costs, since they do tend to be quite cheaper than here in the US. Certain states have been pursuing legislation to make this possible through an importation plan. Each proposal needs to be submitted and approved by the Secretary of DHHS. And I believe that as far as we're concerned right now, is that they're all just waiting for feedback at this point. So as I've said earlier, the Hatch-Waxman Act opened up the generic drug market to tremendous growth, and we've seen an increase in overseas drug manufacturing facilities through this time as well. So now these facilities can pose some challenges for the FDA, and it has not been without issues. So to start, the FDA can show up anytime at a facility within the United States, but historically speaking, they would give advance notice to facilities located in other countries. So an analogy that I like to use here is that when you know that someone's coming over to your house to visit, you have a chance to make sure that it looks clean and orderly, but on any other given day, it might be a total mess. So on the other hand, if you may have companies stop by randomly, just drop in, you want to make sure that it's clean, or at least put together, you're doing what you need to do every day in the off chance that you'll have visitors. And so what has happened is that, with these announced inspections of overseas facilities, it does give you some time to kind of go through and say, okay, what are they going to be looking at? Clean up, fix any issues ahead of time when, every other time maybe there were some problems. So what FDA inspectors found is that some of these facilities were using lower quality or unapproved ingredients for manufacturing and manipulating or falsifying data. And there was actually a book recently published that covered some of these issues. So in response, the FDA has increased the number of inspections of overseas facilities to the point where they're actually, exceed the number of inspections of facilities within the United States, with an increase in unannounced inspections. And so in particular with one particular manufacturer in India, in response to some of these violations that they had discovered, the company actually ended up pleading guilty as part of one of the largest drug settlements or drug safety settlements, and paid a fine of $500 million. And so furthermore, the FDA has also banned several of their facilities from providing drugs to the United States. Next, we'll go into ensuring safety, efficacy, and security of drugs. So it's important to understand that after a drug has been approved, it continues to be monitored as it becomes widely used by the public. So sometimes unacceptable health risks may be unveiled as it is used in people beyond those in the clinical trials, or sometimes manufacturers or the FDA find an issue that needs to be fixed. So next, we'll discuss three mechanisms that are used to help protect the public from potential harm, including recall, market withdrawal, and safety signals. So first, starting with drug recalls, they are voluntary removal of a defective product from the market. This can be initiated by the company or requested or mandated by the FDA. And so the FDA's role in this process is to make sure that the company is handling the recall appropriately. So how would you know if a drug has been recalled? So sometimes there may be a public notification by the company, usually if this is more widespread, serious, impacting large numbers of people. There may be an announcement by the FDA via the news or other media. They also release enforcement reports, and they also have a Twitter account that you can follow as well with this information. Or you may be directly notified by the manufacturer, healthcare provider, or pharmacist. And so a few general reasons why a drug may be recalled is for safety reasons, obviously to prevent further harm, mislabeling, contamination, or variance in strength or potency. And so this can be due to the product itself or the labeling and or packaging of the product as well. So you may be asking, are all drug recalls serious? Not necessarily. There are actually 3 recall classes depending on how serious it is. The first being class 1, which is the most serious. This is where the issue can lead to serious health problems or death. The next is class 2, which is actually the most common type of recall. And this is where the issue may cause temporary reversal health problems and has a slight threat of serious nature. The last is class 3, which is the least serious. And this is where the issue is unlikely to cause adverse health reactions, but ultimately it violates labeling or manufacturing laws. And so they do need to fix that issue. And so what should you do if your medication is recalled? So first, you may want to check to see if your specific medication has been impacted. Many times recalls impact only certain batches of a medication, and you'll typically be able to access a list of lot numbers affected by the recall, and you can check this information on your bottle. So sometimes your pharmacy may get your medication from a larger stock bottle, and so you may actually need to call them to see which lot you received. And they may have unaffected lots of medication as a replacement as well. You also want to make sure to talk to your healthcare provider, since many medications are critical for your health. You typically don't want to stop taking them without talking to your provider first, and they may be able to prescribe you an alternative medication if it's appropriate. So next, we will walk through a notable drug recall that affected a few medications that are used to treat high blood pressure and heart failure, and that being angiotensin II receptor blockers, or ARBs. So back in 2018, there were recalls of a few ARBs, including valsartan, losartan, and irbesartan, in addition to some combination medications containing those ingredients. So it was discovered that certain batches of these medications contain impurities called nitrosamines like NMDA, NDEA, and NMBA that are either probable or potential carcinogens or things that can increase your risk of cancer. And so it was believed that this issue actually dated as far back as 4 years prior. And at least initially, this stemmed from the raw ingredient manufacturer. So if you remember, we touched on ensuring that you're obtaining quality raw ingredients for manufacturing. This was, an example of when that caused an issue, because there was an issue with the raw ingredient. So now you may be thinking, this sounds really dangerous. And yes, consuming large amounts of nitrosamines over a long period of time can definitely be an issue. But we actually do consume low levels of them because they're actually found in some water supplies and foods. But the FDA actually defines acceptable levels in these cases. And so in the cases of these medications, the levels were found to be in excess of what is considered to be reasonably safe for humans. So what did the FDA do here? So to start, they investigate the issue and try to figure out how it happened, which medications have been affected, and what is the actual risk or impact to patients. So through this process, impacted lots of medication were recalled, and they also maintained a list of batches that were confirmed to not contain these contaminants. And so they were actually testing these batches to make sure, which ones had them and which ones didn't, and making that public available. So they also discovered that the impurities may have, at least in part, been created during the manufacturing process. Again, certain things can happen that may not be anticipated. And so this is possible, but it is possible to actually manufacture these medications without creating this impurities, because of course we do have manufacturers and batches that don't have them. And so the FDA also inspected these manufacturing facilities to make sure that they are following cGMP standards, because again, having good, robust testing processes is key, and that's actually how this issue was identified in the first place. One of the manufacturers, getting the raw ingredient from another manufacturer, had tested and found these contaminants in their products. And so they also wanted to put some context around the risk, really assessing that the risk to patients based on the maximum possible exposure. So if you were taking the highest strength medication and getting the most amount of these nitrosamines over this potentially, 4-year period, that your actual risk or increased risk of cancer was very, very small. So what did this mean for patients? So realistically, if you were filling a prescription during this time for one of these medications, chances are you may not have always received an impacted lot. And the FDA, again, advised patients to keep taking their medication until their provider or pharmacist could give them a replacement or a different treatment option. So your next question might be, what is being done to prevent this from happening in the future, or maybe even something worse? And so the FDA has been working with manufacturers and the supply chain to remove any affected medications so they don't, reach any more patients. And they've also been inspecting and citing these facilities to make sure that they're in compliance with cGMP. And they've also focused on ensuring that processes are in place to identify these potential impurities, because again, this wasn't necessarily something that was anticipated to be a byproduct of manufacturing. And so since this initial ARB recall, they've identified similar issues in medications like ranitidine, which goes by the brand name Zantac, which is an over-the-counter medication used to help treat acid reflux, as well as metformin, which helps control blood sugar in type 2 diabetes. So next we'll move on to market withdrawal. So how is this different? Market withdrawal is when a product is taken off the market, and this can be done because the company needs to correct a minor issue. It can also be done for safety reasons. So the company may also withdraw a product because, they may have declining sales and they say, you know what, it's not worth it to keep making this medication. We're going to remove it from the market entirely. And so a market withdrawal can actually start as a recall to protect the public if it could potentially cause harm, and ultimately be completely removed from the market. So one example of a notable recall that has happened for safety reasons is the medication Vioxx. And that may sound familiar to you. So Vioxx was an anti-inflammatory medication that's used to treat different types of arthritis, acute pain, menstrual pain, and migraine. So the manufacturer had actually withdrew Vioxx from the market back in 2004 after a study showed that people taking this medication long-term actually doubled their risk of heart attack compared to people receiving placebo. So again, for safety reasons, they decided to withdraw the medication from the market. So next are safety signals. So, as we're going through this ongoing monitoring of drug safety after approval, sometimes adverse events may come up, and so those need to be reported to the FDA. This is done sometimes by pharmaceutical companies, providers, consumers, and so this information is actually searchable using the FDA Adverse Events Reporting System, or FAERS, public dashboard. And so the FDA takes the information from the system to identify potential signals of serious risks or new safety information. And this information is actually evaluated by the FDA to determine if the drug is associated with the risk that's being reported. And so what if the FDA does find that this drug is associated with the risk? So they do have a couple different tools or methods or processes on how to manage this. And so they may decide we just need to update the labeling. And so they may update the medication labeling to include these newly identified risks. They may require a REMS, or a risk evaluation and mitigation strategy, which is a drug safety program required by the FDA. And so this may include a med guide, which is a handout given to patients when the medication is dispensed. It may include training and certification of providers, specific patient testing or monitoring, just to give a few examples of what that might entail. They may decide to remove the drug from the market. So again, if they have all these reports of these serious issues, they find that, yes, the drug is associated with this, and through their review, they may advise that the drug is removed from the market. They may also need to just gather more information. So, we have this information and they need to better characterize the risk to patients. So here are a few potential causes of safety signals that can include, but are not limited to. So again, a lot of times it's an adverse reaction. There may be some allergies, drug interactions, and may interfere with certain procedures or lab tests. There may be some quality or dosing issues, preparation errors, medication errors, therapeutic inequivalence. Again, maybe the drug, maybe the labeling. Sometimes the labeling can be confusing, so people are using it incorrectly. And so all these are some examples of when safety signals may come up. So we'll walk through a few FAQs before we wrap up. So is the FDA slow at approving new drugs? I think we probably hear that a lot. And actually, compared to other countries, the FDA process can actually be faster. They do have expedited pathways for certain drugs to get to the public faster, as we've kind of discussed earlier. So drugs for cancer, rare diseases that maybe there aren't a lot of patients, and so there's some incentives to develop new treatments for those conditions. Next, why do new adverse reactions pop up after a drug has been approved? So again, when you're testing a drug or studying a drug within a clinical trial, it's within the confines of a smaller group in a more controlled environment. And so when the medication starts to be used in the broader population, new, rare adverse reactions can be uncovered. And so that is why ongoing monitoring of drug safety is important. Lastly, can there be adverse reactions that happen but aren't from taking the drug? Yes. So just because there is correlation does not mean that there is causation. And so, within normal process, we expect a certain number of events to happen within a population normally. So we'll have heart attack, stroke, death, things like Bell's palsy, for example, which has come up, that happen normally. And so just because it happened within someone taking the medication doesn't necessarily mean that the medication is what caused that. And so there does need to be further investigation to confirm if it's actually from taking the drug. So a few main takeaways. So I think it's really important to note that the FDA is by no means perfect. And I think we've kind of walked through a lot of the processes and some of the issues that have come up over time. And they do rely on studies and information from drug sponsors as well. But hopefully this has helped you get a better idea of some of their more significant functions and roles in drug safety. So all drugs have risks, like we've said. So we talk about a drug being safe and effective, doesn't mean it's without risks. And the FDA approval process evaluates whether the benefits outweigh the risks. And the drug labeling gives us information on how to identify and manage these risks. But not all risks may be known when the drug is approved. And so we do monitor the drug's safety after it is approved and is being used by the general population. And lastly, generic medications should work in the same way in your body and provide the same benefit as the brand equivalent. But there are some instances when you need to or should take the brand version. And so that wraps up the presentation. And so I'd like to go ahead and thank everyone who joined the session and to enjoy the rest of the day.
Wow, that was a really informative talk, giving us all a much deeper understanding of the work put in to get our medications as safely as possible. We are about to go into the final portion of our program. As a quick reminder, visit our raffle page if you're interested. It's your last chance to enter. Your wellness box included a puzzle because puzzles are a great way to keep your mind active and young. Our next speaker is a true expert when it comes to figuring out clinical puzzles. Dr. Richard Wright is our brilliant leader at Pacific Heart Institute. He is co-director of the California Medicare Contractor Advisory Committee, chair of the American College of Cardiology National Carrier Advisor Committee, and Cardiology Advisor for Medicare's Relative Value Update Committee. Dr. Wright normally travels the globe lecturing on all things cardiology, but this year his patients were fortunate to get to see him always in the same time zone. In an effort to understand how recent medication advances can help us live longer, Dr. Wright will be presenting on updates in pharmacotherapies in cardiovascular disease. Like earlier, we will have about 10 to 15 minutes at the end of this discussion for a live question and answer round with Dr. Wright and Dr. Billingsley. So please make sure to submit your questions throughout this presentation using the Q&A button at the bottom of your screen. Now here's Dr. Wright.
Well, thanks for the great introduction. Thank you for joining me as well. I'm going to give a talk today about the use of medications. And as the title says, this is really about the rediscovery of medicines that may have been around for a long time, but that we have new uses for. And please save your questions till the end. We'll have plenty of time to address whatever questions you may have. So the title of this talk is Repurposing Medicines 2021, as I mentioned. And I put in the little moniker there of something old, never new, always borrowed, and sometimes blue, because as I hope to convince you, one way that we can help patients live longer and live better is by appropriate use of medicines, some of which have been around a long, long time. These are my disclosures. Some of these companies make medicines which may be referred to in the talk today, although I will tell you that I don't have any conflicts with regard to any finances about these particular medications. So what do we mean when we say repurpose? As you can see, the dictionary definition here is to adopt something for use in a different purpose. Now, sometimes these Venn diagrams, if you will, overlap. That is, a use may have similar uses, but I'm going to talk about medicines that were originally developed for something entirely different than what they ended up being used for in the cardiovascular arena. And we're going to talk specifically about how pain relievers have been now utilized to prevent heart attacks, how medicines developed initially to treat the chest discomfort that accompanies narrowed arteries, we call that angina, can be used to prevent death in patients with heart failure. I'll talk about high blood pressure medicines, which have been repurposed to treat heart failure or to prevent its appearance. I'll talk about newer drugs that were developed initially as diabetes remedies, but which will turn out to be more useful for treating and preventing heart attacks, heart failure, and kidney failure. And finally, an old remedy for gout that has been repurposed to treat patients in hopes of preventing heart attacks. And I'd like to start just by going back to somebody who lived 150 years ago. This is von Rokitansky. He is an Austrian, and he's the father of modern sort of anatomical forensic pathology. He himself did 70,000 autopsies. And as such, there are over a dozen anatomic features which are named after this particular gentleman. And despite being an august professor at a university, what he said was those about to study medicine and the younger physicians should light their torches at the fires of the ancients. As my mentor back in Boston said, you really need to apprentice yourself to very smart people so that you will get a good grounding. And that's what Baron Karl von Rokitansky said 100 years ago. So let's go back in time, and I'm going to go way back. This is a depiction of an ancient Egyptian papyrus. This was compiled in about 1500 BC. We're not sure exactly. It's a very large document. It's 30 meters long. And what it is a compilation of 2,000 years of medicinal recipes dating back to the ancient pharaonic times, and including many things which are, believe it or not, still used today. There, in this document, there are surgical tips and wound tips and things, but there are almost 900 different pharmacologic recipes. And because they had a limited number of things from which to make these medicines, over 100 of these included castor oil, for example. Now, not everything in this document is applicable to modern times. And part of it, even though the document says that there are some medicines that can put the heart into working order, remember that in ancient times, they didn't know what the heart did, and they didn't know its function, partly because they were not allowed to do human anatomical dissections. And it wasn't until 3,000 years later that the function of the heart was discovered. But within this document, there's some very interesting things, obviously much of which can be ignored. Here's one in yellow: using excrement of the gods to treat tremors. I have no idea what excrement of the gods is, but the next line says human excrement mixed with yeast and honey is recommended to treat wounds. And if you keep reading, it says that male semen can be used for other purposes. But in this document, there's some surprising findings. Here's one. In the Ebers Papyrus, there's reference to using the bark of a willow tree to treat individuals with aches and pains. Now, this was 4,000 years ago, this was discovered. It was codified, however, by the father of modern medicine, Hippocrates, in ancient Greece. And he actually wrote that you could give willow leaf tea to women to ease the pain of childbirth. So here we are, over 2,400 years ago, when already there was a remedy for pain relief. That was the extract from the willow tree. Now, medicinally, fast forward 2,000 years, and finally, it was begun to the beginnings of understandings of how this worked. In fact, in 1763 in London, this particular vicar, actually, Edward Stone, described how you could use willow bark to treat various things. And about 50, 60 years later, in Germany, the active ingredient from these plants was discovered and named. And about 30 years later, 25 years later, the chemical structure was deduced. And notice in the line here in the middle, I say acetylsalicylic acid was produced. That was in 1853, but this particular French chemist didn't have the wisdom to patent that particular device. These medicines were used at that time to treat aches and pains and fever, as is listed here in 1876. But it was in the late 1800s that this was finally discovered as to exactly how this worked. And it was discovered in Germany. A chemist who worked for Bayer Pharmaceuticals found that if he took the active ingredient from the willow plant and other plants, and he added a chemical group to it, that you would reduce the irritant properties. If you use the medicine that comes from the willow plant, it irritated the stomach. So he had the ability to chemically play with the molecule, and he came up with this name, the compound acetylsalicylic acid, which within the next years was patented by Bayer and was named aspirin. And as listed here, aspirin was actually a combination of acetyl, which was the thing that was added to the salicin. Salicin comes from a bunch of plants, one of which is this genus Spirea. That's where the spur comes from. And the IN was a common suffix used when naming medicines for the time. So aspirin was actually a branded trade name. It's not a generic, it's a branded trade name. Of course, many years ago, it lost its patent potential. Interestingly, the next year, Bayer was ready to shelf aspirin and not to use it, not to market it, because it didn't think it had marketing potential. But when you look at the documents in the German history there, the real reason was Bayer had also just invented heroin. And they said heroin was going to be a good cough suppressant and it was non-addictive, which shows you how scientists can sometimes be misled. Fortunately, others in Bayer decided that aspirin did have a future and brought it, as depicted on the right of the slide, to market for use for both its anti-fever use and to reduce pain and suffering. Now, here is the chemical structure for any chemists in the audience. Salicylic acid, which is the fundamental plant compound, and then acetylsalicylic acid on the right. And it's this acetyl group that is the key to the use of aspirin for heart disease prevention. Nobody knew how aspirin worked, even though it's been around in use for 4,000 years. It wasn't until 1971 that somebody actually was able to determine how it worked. And here's the gentleman who did it, John Vane. He's was a British pharmacologist, who at the University of London figured out that aspirin worked by interfering with some natural substances called prostaglandins, and it prevented prostaglandin production, and that's how it had an anti-inflammatory effect. So that anti-inflammation works for aches and pains like rheumatism, rheumatoid arthritis, etc. But it turns out it's not the anti-inflammatory effect that helps me as a cardiologist treat patients to prevent heart attacks. His work, by the way, won him the Nobel Prize in 1982. Aspirin, it turns out, prior to John Vane's discovery of how it worked, was already being utilized here in the greater Los Angeles area by what I call an unsung hero. This is a picture of him. We don't know a lot about him. He died more than 40 years ago. But this was a general practitioner in the LA suburb of Glendale, California. And he recommended, here's his actual recommendation that he published in 1948. He said he recommended an aspirin a day to reduce future heart attack. And the reason he deduced this was because he had had a lot of patients. And what he said is that he had noticed that his children that were given chewing gum that had aspirin in it, that's how babies were given, or kids were given aspirin at the time, that they seemed, if they were given aspirin after tonsillectomy, to have excess bleeding. And he had believed that heart attacks were due to thrombosis in the coronary arteries, at that time called coronary artery thrombosis. And so therefore, A leads to B and B to C, and he deduced that if aspirin caused bleeding in kids, that maybe it would prevent clots in adults, and he recommended in 1948 that this be undertaken. So here's his recipe, 1948, an aspirin a day for men between 45 and 65, particularly those who are now we know at risk, like overweight or sedentary. He made the same recommendation for his patients who'd recovered from heart attacks. And his advice, as I mentioned, was based on his overview of 8,000 patients that he had in his practice. And he reported this, unfortunately, and this is still pervasive today, that medical journals tend to ignore people in the community and instead to only publish articles from people who are at major universities. He was a general practitioner in Glendale, California, and his advice was summarily ignored, partly because who reads the Mississippi Valley Medical Journal? So even though some people read it, they said, oh, these are just observations. No one listened, including, by the way, President Eisenhower's physician, a very august cardiologist from Boston, who was the most famous cardiologist in America. In 1955, Ike had a heart attack and aspirin was not administered to Eisenhower. Instead, he was given the more potent anticoagulant warfarin, which we know is actually less useful than aspirin. It's too bad that Paul Dudley White, the cardiologist in 1955 for the president, didn't listen to Dr. Lawrence Craven's advice. And in 1957, Dr. Craven died, ironically, from an acute heart attack. So that was 1948. Let's fast forward to the first trial of aspirin. So there was this smoldering thinking, maybe aspirin would help people after heart attack. And in 1971, a study was embarked upon. It was published in 1974. So we're talking more than 25 years after Dr. Craven's advice. And on the right is the figure from that particular article showing that aspirin versus placebo did seem to have a benefit. However, if you look on the upper left of this slide, see how it says for debate. The problem with this trial was it was stopped prematurely. They didn't have enough people enrolled into the trial. They only looked at fatal heart attacks. They didn't look at people with subsequent heart attacks or the development of unstable symptoms of angina. And hence, statistically, this didn't quite reach statistical significance. And therefore, they said it's unproven. We don't think aspirin necessarily is helpful. Why was the study stopped early? Because an observation done by an epidemiologist said that if people were taking aspirin versus not taking aspirin, the ones who were not taking aspirin were more likely to survive their heart attack. But the reason was, in retrospect, is if you were taking aspirin, you weren't going to have the heart attack that was going to kill you in the first place. So they misinterpreted these epidemiologic data, and hence this study in 1974 was not widely embraced, even though it was the first showing that aspirin made a difference. How does aspirin make a difference? Here is a depiction in this yellow color, the flesh color here, of a platelet, cells that circulate in your bloodstream. And these are the first body's defense to form a clot. And aspirin works in this green area over here, inhibiting an enzyme called cyclooxygenase. If you inhibit that enzyme, you prevent a prostaglandin being produced called thromboxane, and that substance amplifies the platelet's ability to clot together to form a little cork. If your artery has a rent in it, you don't want to bleed to death. These platelets plug up that hole in the artery, and they do so in part by this particular prostaglandin that is blocked by aspirin. This is a depiction of the enzyme. And it's interesting that other so-called non-steroidal anti-inflammatory drugs, you may take naproxen, which is Aleve, or ibuprofen, which is Motrin, for example. And those things, it turns out, also block this, but in a different way. This is a cartoon of the cyclooxygenase. It's a dimer, two different proteins, and there's a site in there that makes this substance thromboxane. It turns out that that site is interfered with in the right panel here by all non-steroidal anti-inflammatory drugs. However, unique to aspirin, this acetyl group, which, as I mentioned, back in Germany in the late 1800s, was added to salicylic acid. That acetyl group is donated and binds to the catalytic site inside this protein, and hence permanently disables that enzyme. This is why if you take an aspirin, even at a low dose, all the platelets that are currently circulating at the time that you take a platelet are paralyzed by this acetylation. And that isn't true of ibuprofen or naproxen or Celebrex or any of the other non-steroidals. And this is why aspirin is unique amongst the non-steroidals at having a durable effect at preventing clots and heart attacks. So how does it prevent heart attacks? Well, here's a depiction of your artery, hopefully not your artery, but an artery of patients who will see their cardiologist. And starting perhaps as early as age 18, fat deposits of cholesterol and other substances build up. And then finally, a clot may develop. And that clot is what aspirin helps prevent. And of course, that clot is the cause of 95% of heart attacks and a cause of many strokes as well. So aspirin will produce a benefit, both in preventing heart attack and also in preventing strokes. So in 1974, we had the first publication, but it was dismissed because it was inconclusive. And it wasn't until many years later, here in 2009, that they put together all the aspirin studies up to that time and showed that all vascular events and heart attacks were indeed prevented. And the bottom line is that if you give an aspirin a day to appropriate people, you will lower heart attacks by about 20 to 25%. The number's right around 22%. A really good return on investment because aspirin is very cheap. Now, should we give it to healthy people? This has been, in fact, studied in very large trials, including 2 within the last year. Here's the most recent, just published in 2021, within the last 2 weeks. And it's studied by a Canadian epidemiologist who gave, in 5,700 individuals considered at risk, these are not healthy people. These are high blood pressure individuals, high cholesterol, diabetics, in their 60s, and you give them an aspirin or not, and you can see that over the next 5 or 6 years, aspirin does help prevent cardiovascular events compared to no aspirin. This is direct head-to-head in a blinded fashion. However, if you look at these data more closely, what you find is that it takes a lot of people to prevent one heart attack. You have to treat hundreds and hundreds of people to prevent one heart attack, stroke, or cardiovascular death. And remember that aspirin has one downside, and that is if you paralyze the platelets, some people will bleed. And the number who bleed is about 1 per 100. So if you have to treat 700 people to prevent a heart attack or stroke, but you cause 7 people to bleed, it's not clear that that's a good return on that aspirin investment. And that's why the current thinking is that healthy adults who do not have vascular disease do not benefit from an aspirin, at least from the heart perspective. So what can we summarize about willow bark? 4,000 years of use of willow bark and eventually aspirin. It lowers heart attacks and cardiovascular deaths, no question about that, but only in appropriate patients, not in normal, healthy people who do not have vascular disease. It's best to use non-coated aspirin because the enteric coated aspirin labeled as safety or coated does not get absorbed in up to 25% of people, and hence I only recommend non-coated chewable baby aspirin flavored like cherries or oranges, just like you took as a child. And for 95% of people, 81 milligrams, that's the typical American adult low dose aspirin. In Europe, it's 75 milligrams, but somewhere between 75 and 100 milligrams is all that is warranted and required by about 95% of people. By the way, those of you who think there's resistance to aspirin, there's almost no such thing. If you give intravenous aspirin, it works in over 99% of people. Somebody who's so-called resistant to the effects of aspirin usually means they're not absorbing aspirin. And that's why we recommend giving the aspirin in the non-coated variety. Now, that was something old. I want to go to something borrowed. And this is borrowed from this snake, the Brazilian pit viper. 50 years ago, it was noted that farmers who are working in the field in Brazil, if they were bitten by the snake, would have a sudden and catastrophic reduction in their blood pressure. And from that observation, people said, well, maybe we can extract something from the viper's venom that might lower blood pressure. Maybe there's an antihypertensive agent in the Brazilian pit viper's venom. And the same guy that I just talked about, who won the Nobel Prize in 1982 for discovering aspirin, was the key person who said, let's explore this. And he introduced this, actually, even before his aspirin work, to some colleagues to say, let's see if there's something in the Brazilian pit viper's venom that might lower blood pressure. He knew that there was an intrinsic hormonal system that regulates your blood pressure. This is what's going on right now in you to regulate, along with other systems, your blood pressure. It's called the renin-angiotensin-aldosterone system. And in concert with the brain and the kidneys and other organs, the body makes hormones that either up the blood pressure or can lower blood pressure. Mostly it's upping the blood pressure, these hormones. It turns out that one of the enzymes here called angiotensin-converting enzyme is the rate-limiting step in producing these substances that elevate blood pressure. And in the Brazilian pit viper's venom, it turns out there was a substance that blocks that enzyme. So these chemists in England, working at the suggestion of John Vane, discovered substances. They went through over 2,000 different substances to find one that would modify the enzyme's activity and lower blood pressure effectively and not catastrophically, like happened with the Brazilian pit viper. And the first of these that was patented and came to market was called captopril. Now, captopril was put to the test, or rather the son of captopril was put to the test in a very large blood pressure trial. So let me show you that, in fact, this does lower blood pressure. This is the largest blood pressure trial ever done. 42,000 people, 4 different drugs were pitted against each other to say, is there a difference between blood pressure medicines? The study is old. It's almost 20 years old now. We actually participated in this particular study here at Pacific Heart Institute. But here's the bottom line. Notice that there are 3 drugs on this slide. One of the drugs used, called doxazosin at the time, actually early in the study was found not to be as effective and more harmful, and it was dropped from the study. So that tells you right there that not all blood pressure reducing drugs are the same. Here is the blood pressure reduction. On the left is the most important marker, which is the systolic, the first of the 2 numbers when you have your blood pressure taken. And notice that the average blood pressure on enrollment in this trial was about 145, and it dropped to about 135. And that is typical. Most blood pressure drugs at this type of range of blood pressure lower blood pressure by 10 points. Notice that there was a difference even between these 3 drugs used at good doses. In green is the most common ACE inhibitor, son of captopril, called lisinopril. Many of you may be on lisinopril. And it's an effective blood pressure reducing agent. Notice that it does promptly and effectively and safely reduce blood pressure, although surprisingly not quite as well as the red drug here, which is amlodipine, another commonly used drug, or this so-called thiazide type diuretic. In this case, a long-acting thiazide type called chlorthalidone. So for blood pressure reduction, there's a pecking order here, and it turns out chlorthalidone was actually better when given randomly to people than the ACE inhibitor lisinopril. But for the cumulative events in this trial, which was did somebody have a heart attack, didn't matter, right? The drugs didn't seem to differ, even though they were different for blood pressure, they didn't differ by heart attacks over the ensuing 5 years. Now, it turns out part of the reason for that is lowering blood pressure is not a very good way of preventing heart attacks. There are better ways to prevent heart attacks. I just showed you one, aspirin. The other one, of course, is statins to lower cholesterol. Blood pressure drugs in and of themselves are not very effective. There is a difference, however, for stroke. And again, here, lisinopril didn't quite do as well as either chlorthalidone in yellow or red amlodipine. And there are little nuances of which patients respond better, but you can see that there is a little bit of difference for stroke prevention with these particular drugs. And if you combine all events, they're pretty similar, although because this is a large trial, the victor here compared to lisinopril was the thiazide type diuretic. So these subtle distinctions you can discuss with your physician if you happen to be on treatment for high blood pressure. So ACE inhibitors were found right away to be useful for high blood pressure, but it turned out that wasn't their major niche. Their major niche was treating heart failure. So what is heart failure? Heart failure is a syndrome like fever, right? Fever isn't a disease. They used to think it was. It isn't. Heart failure means the heart is not working. It doesn't deliver adequate blood at an adequate pressure. Right? That's what heart failure is. When we think of heart failure, and the drugs that I'm going to discuss in the following minutes for heart failure is a specific variety of heart dysfunction that we call heart failure with reduced ejection fraction, or systolic heart failure, the common kind in the past of heart failure, which means the heart on the left here is stretched out. It becomes more spherical instead of oval in shape, and it's weak. So we express this by a number called ejection fraction, how much blood can be ejected per beat by the heart. Your heart hopefully is normal and is ejecting 60% or so of the blood contained within the heart chamber during each beat. But these people may have an ejection fraction of 40 or 30 or 20 or 10, where the heart is just not very strong and it cannot pump blood very effectively. That's where ACE inhibitors turned out to have an edge. Because when pitted against no ACE inhibitor, here's another son of captopril. Captopril works, but it was too short acting. So drugs like enalapril and lisinopril were developed that would last 12 to 24 hours. And if you pit those against placebo, and this is death on the vertical axis, that if you have somebody with reduced ejection fraction heart failure, they live longer if they're given enalapril or any of the ACE inhibitors compared to no ACE inhibitor. So that was a bingo moment. ACE inhibitors, yes, they lowered blood pressure, but they didn't seem to save lives differently than other drugs. But here we had, for the first time, a drug that could prolong life of people that had a weak heart and reduced ejection fraction heart failure. And in fact, over the following years, a bunch of studies were done with different ACE inhibitors. The vertical axis is the death reduction. And across the board, there was about a 20% reduction in death in people with reduced ejection fraction heart failure. So this was an enormous advance in treatment of heart failure, because up till that point, somebody with a weak heart, you could mollify their symptoms, but we had no known way of prolonging their life. Now, I must tell you that ACE inhibitors were terrific, but that was 25 years ago. They have subsequently been superseded by better agents. So if you come to see me for treatment of heart failure with reduced ejection fraction, I'm not going to put you on an ACE inhibitor anymore, because son of ACE inhibitor, here called sacubitril plus valsartan or Entresto, works better in a head-to-head analysis. And that's true whether you look at death or whether heart failure, hospitalizations, it's been superseded by better drugs. Nonetheless, ACE inhibitors were the first widely used therapy to prolong life in heart failure patients, and they've now been eclipsed. But this was a sentinel moment showing us that we could, in fact, help heart failure patients. And this came from observations of Brazilian farmers dying in the field of shock from a venom. But there are other ways to treat the failing heart. And again, this is a repurposing of a medicine. Here's another Nobel laureate, another Brit, James Black, who really was remarkably bright in thinking sort of what I call the Gretzky approach of where the puck is going to be. Sir James Black, he was later knighted, as you can see here, won the Nobel Prize in 1988. And the way he won the Nobel Prize was because he invented, and that's the right word, invented beta blockers. Unlike the medicines that I just told you about that exist in nature, beta blockers do not exist in nature. These are an invention of man. And this thought of his was stimulated by the unfortunate demise of his dad. He was in, Sir Black was in medical school, and his dad died of a heart attack, having had angina before. And at the time, it was felt that angina and heart attacks were in part precipitated by rapid heart beating. We know that the heart beats rapidly in response to norepinephrine, or otherwise called adrenaline. That's what they call it in Europe. And so he had this concept that if you could take adrenaline and modify it, maybe you could bind to wherever adrenaline binds. At that point, nobody had discovered these receptors where adrenaline binds, but he conceptualized there must be such receptors. He knew from a previous scientist named Alquist that receptors existed. Nobody had purified them. And he said, if we modify adrenaline, maybe we can make it like an umbrella and sit over the beta receptor on the cells and therefore prevent the cells from seeing adrenaline and hence slowing the heart. He wanted to stop the effects of the heart from adrenaline on the heart and therefore improve angina. That was his goal. This was, in fact, the first of the designer medicines that came to market. It was patented in 1962. It's still in use today. Propranolol, some of you may be on it. It's mainly used for tremor reduction now because it's a short-acting medicine and has again been supplanted by other beta blockers. Later, it was found to lower blood pressure. That's not why the medicines were developed. They were developed to reduce heart rate. Today, we use them all the time to reduce heart rate, to prevent tachycardia, which means fast heart rate. And they are also used as blood pressure agents, although they are not the best blood pressure agents on the market. But again, the thinking was not quite right when beta blockers first came out. And indeed, the medical thinking back in the 70s, after the initial introduction for the first few years of beta blockers, was that these drugs should be avoided in heart failure patients and in angina. In fact, here's a quote directly from a medical book in 1978. Because patients in heart failure are critically dependent on sympathetic activity of the heart to maintain cardiac output, you must avoid beta blockers in these patients. And that was 100% wrong. It was one of those things that we thought made sense, but turned out to be completely wrong. Now, I will tell you, there is still thinking. Last week, I went on Wikipedia and I downloaded this quote. This is from January of 2021. Beta blockers should not be used in those with an already slow heart rate and most of those with heart failure. Wrong, wrong, wrong. And here it is in what many of you do when you use Dr. Google as your advisor. Why were these smart people and even Wikipedia misled? The reason is because in red here is a normal heart, in green is a heart that has just been removed from somebody who underwent a heart transplant. Their heart was so weak they needed a heart transplant. And in red, what was known at the time back in the 70s, left to right is heart rate, and the vertical axis is the strength of the heart. In red, the normal heart, as it speeds up, it beats more strongly. This is why when you run or do any athletic activity, your heart is a better pump, in part because it beats better when it's faster. But it turns out the failing heart does not do this. The failing heart is exactly the opposite. The program, the genetic program of the failing heart has been altered such that it hibernates a little bit and the heart, to protect itself, gets weaker with faster heartbeats. It doesn't get stronger. And hence the notion that if you slowed the heart in the normal person, you would indeed weaken the heart. But in the green column, the green graph here, notice that if you gave a slower heart rate to a failing heart patient, the heart will get stronger, paradoxic compared to normal physiology. And indeed, here are the data. The vertical axis is this number I introduced you called ejection fraction. These people with heart failure had a low ejection fraction of 25%. When given the standard of care back in the day, their ejection fraction remained stable. But when given a beta blocker, metoprolol, one of the beta blockers, the ejection fraction rose. No modern medical therapy has exceeded this rise. The average rise in ejection fraction on appropriate beta blockers is 9 percentage points. That means these people went from 25 to 34. That is huge and not replicated by any medicine since then. But does that, in fact, that improvement save lives? Here are all of the large randomized beta blocker trials. And if you look on the right here, this is the death rate reduction over a brief period of time, 10 months, 12 months, 15 months. You reduce death rates by 35%. And that is just stunning. One other point. Within the normal range of heartbeats, the failing heart does much better if it goes slower. If you walked into a doctor's office with heart failure and your heart rate was 75 or 80 in green here versus 70 to 75 in this pink color versus 65 in yellow or 60 in orange or below 60 in purple, the vertical axis here is the heart failure outcome, death, heart failure hospital stay. And notice that people who have slower hearts do dramatically better. This isn't like a little incremental gain. We must, in heart failure patients with low ejection fraction, lower heart rate, to a greater degree than what most doctors are doing today. So the resting heart rate in such patients using beta blockers and other therapies should be down at 60. And I can tell you that that is achievable when using appropriate medication. Now, a couple others in closing. Diabetes treatment. Nobody can look at this. These are the current diabetes medicines. Are you kidding me? There are 11 classes. There are like 50 different drugs. It's unbelievable. All of these lower blood sugar, all of them. And that's why they were developed as diabetes drugs. But it turns out most of these drugs, in fact, 9 of the 11 classes of diabetes drugs, do nothing to prevent heart attack, stroke, kidney failure, death, nothing. They lower blood sugar, but they don't lower these events. And why is that important? Because diabetics don't usually die of diabetes. What they die of is premature cardiovascular death. If you have diabetes, your life, if not appropriately treated, will be 7 years shorter than the other people in your community with similar age and demographics who don't have diabetes. So what can we do about that? Well, fortunately, new medicines have come to the rescue. Here's the latest. These are called SGLT2 inhibitors. Here in this cartoon in red is the blood vessel that goes, these small blood vessels that go to your kidney. Now, as you know, the kidney is an organ which is supposed to filter noxious substances out of the blood. But the filter is permeable, and in green are sugar molecules, glucose, that are circulating in the blood, but they make it through the sieve of the blood vessel and make it into the beginnings of urine. This isn't actually what's secreted into your bladder, but this is the beginnings of urine. And prior to elimination from the kidney into the bladder, the kidney has the opportunity to suck this sugar back up into the bloodstream. And it does so through a protein channel called the SGLT2 channel. This SGLT2 protein is very effective at sucking up all the sugar that would otherwise be eliminated into your urine. And that was important in a time when we didn't have access to calories, right? I mean, if you were living in the plains of Botswana trying to feed yourself, it's important not to lose calories. If you block this protein, however, the sugar that is filtered doesn't have the opportunity to get reabsorbed, and it's eliminated in the urine. Well, that lowers sugar, no question about it. You can eliminate a lot of sugar. But because there was concern that diabetes drugs were killing people, the government mandated that so-called outcomes trials be done. Give diabetics the medicine. Do they do better than those who are not given the medicine, or did they do worse? Are there more heart attacks? Are there more deaths? And surprisingly, when these SGLT2 inhibitors were tried, here's one, canagliflozin, here's another, dapagliflozin, here's another, empagliflozin, and there are others. To the left of this line of unity means that the drugs save lives. To the right, they don't save lives. And the remarkable thing is that for the first time, in fact, these were so stunning, people didn't believe the original trials. No, diabetes drugs can't possibly save lives in 18 months or whatever. But they did, repeatedly, over and over. And in fact, if you look at cardiovascular events, again, here's the line of unity. If you look to the left, means that there are fewer events. To the right, there are more events. And whether you look at this dot, which is cardiovascular death, as well as heart failure hospital stays, if you look at heart failure, being admitted to the hospital, if you look at kidney outcomes, if you look at death, all-cause death, every single one of these was in favor of people being treated with this class of drugs. Now, I will tell you, insulin doesn't do this. Metformin doesn't do this. Most of the other drugs that are used for diabetes don't do this. This was a sentinel observation. Unbelievable. In this particular analysis here, 38,000 patients are on this in this particular analysis. So hugely beneficial, particularly in heart failure. Now here is a stunning observation. In those trials, some non-diabetics got into a trial of diabetics. And it looks like that the people who were given in blue versus not given in red, this particular class of drugs did better even if they didn't have diabetes. This is a diabetes drug being used in non-diabetics. In fact, my prediction is that these drugs will become standard of care. As of January 1st of 2021, across all 51 hospitals in the Providence system, we are now encouraging and measuring the use of these drugs in people with reduced ejection fraction heart failure. And more recently, it's been shown that it prevents kidney dysfunction. So this was true even in non-diabetics. How could that be? Well, it turns out that if you're diabetic and have high sugar, lots of sugar appears in the urine. And so it's felt that some of the benefit, certainly for lowering sugar, is because you excrete lots of glucose into the urine. But in non-diabetics, they don't have a lot of sugar appearing in their urine. And in fact, this drug does not lower it does not increase the amount of sugar being excreted in the urine in non-diabetics. So it works in some other way. We don't know for sure what way. But just in the last week, what they've shown, here's the most important, on the left here in the middle. Left ventricular ejection fraction given to people who do not have diabetes, do not have high blood sugar. And if you give them an SGLT2 inhibitor, their ejection fraction goes up 6 percentage points. I already told you that beta blockers increase the ejection fraction 9 points. ACE inhibitors, the old ACE inhibitors, only increased it 2 points. Here's a class of drugs that increases at 6 points, even in non-diabetics. And if you look at these other ones, these people feel better, they walk better, their hearts get smaller, and this all occurs in the first week or two after starting this drug. So these drugs are miraculous in ways that we do not yet understand at helping patients. So my prediction is they'll be used widely, even in non-diabetics. And it turns out there's a glucose transport in the gut. And just in recent weeks, it's been shown that if you block that and increase glucose secretion into the gut, that you also will have some benefits. So we're awaiting further data about the so-called SGLT1, which is the gut glucose receptor. Lastly, gout. Hopefully none of you have had a right foot that looks like this. This poor individual, left foot is normal. Here in the toe joints here are crystals of uric acid deposited. These are like miniature daggers, and they are very, very sharp and very pro-inflammatory. And if they deposit in your joints, you get this horrible pain and inflammation, which we know of as gout. Gout was known about 4,000 years ago. The Ebers Papyrus says, if you have rheumatism and swelling, like I just showed you, use this plant, the autumn crocus, Colchicum autumnale. So this was widely accepted thousands of years ago by all these august physicians across the world, in Greece, in Persia, in France, in England. It was even used for edema in London in the 1700s, and we may get to that here in a minute. And in fact, it was introduced into America by Benjamin Franklin, who had gout. But the active ingredient of that was not well known. But in 1800, somebody discovered that in this plant, been around thousands of years, that there was a substance that this person named colchicine. Right? And the first trial of this, even though it had been used for 4,000 years, was in 1961. This shows you how sometimes people accept stuff and it hasn't been, in fact, proven in a scientific manner. This first trial was not randomized. The first randomized trial was in 1987 in New Zealand. Unbelievable. It's also used for as many of you who are plant advocates know, in horticulture for other reasons. So here's the observation, though, that led to how this drug has become widely used. Patients with gout have more heart attacks, as do all people with arthritis for the most part. And in fact, it was found that if a gout patient was on colchicine, they had a lower incidence of heart attack and stroke, but only when they were taking their colchicine. It wasn't that they had elected to take colchicine, it was the act of taking colchicine that lowered their risk of heart attack or stroke. Now, this is observational, it's very suggestive, but it had to be put to the test. And it was first put to the test and published in 2019, that if you took somebody with a heart attack and treated them with the normal stuff, if you've had a heart attack, you know that you're going to get a statin and an aspirin, and maybe you have a stent with another platelet drug, et cetera, et cetera. On top of that, if you gave colchicine, there were fewer heart attacks. So for the first time, it was shown that this drug, which was developed for gout and arthralgias, was useful to prevent heart attacks. And just in recent months, a very important study saying, what about people who haven't had a heart attack but are at risk of heart attack? Do they benefit from colchicine? And the answer is convincingly yes. Blue is no colchicine with normal therapy. Red is colchicine plus normal therapies. This is a study of 5,500 people. And look at this so-called hazard ratio. The people given colchicine had a 31% reduction in the likelihood of dying or having a myocardial infarction or stroke or needing an angioplasty or bypass surgery. So huge, huge data. How does this work? These are cells. In red is the architectural tubules, we call them, in the cells. And it turns out inflammatory cells need these tubules to do their work. Colchicine interferes with these microtubules, and the inflammatory cells can't do their job. So anti-inflammatory medicines finally are now shown to have an effect. They finally arrived. This has been a concept for a long time, but they finally arrived to prevent cardiovascular events with an old drug from 4,000 years ago called colchicine. We're not quite sure of the exact drug, the exact dose, the timing. Do people need to be on this forever? It's so new. We just don't have these data for heart patients. But certainly for gout patients on colchicine, the current advice is don't go off it because it'll help prevent heart attacks. So let me, in closing, just say that many patients are, in my view, being inadequately treated. We have terrific medications. These medications make an enormous difference, as I hope I've convinced you, but they're being widely underutilized, partly because patients say they don't want to take medicines, right? They would prefer a natural approach. Well, you can chew on willow bark, and I guess you can use other natural approaches like these plants, but why not avail yourself of modern science and use something that has actually been purified? If you do, treating cardiovascular disease, I don't consider to be rocket science. It isn't rocket science. It's actually much harder than rocket science. Rocket science is pure and simple math. You plug it into a computer, and that isn't how people work. But with appropriate aggressive medications and close follow-up and attention to detail for every person as an individual, from a cardiovascular perspective, many lives can be saved. And I thank you for your time, and I look forward to your questions.
Thank you so much for that wonderful understanding of what the pharmaceutical realm is doing to help us stay forever young. We received lots of questions. I'll start with a question for Dr. Wright about the SGLT2 inhibitors for non-diabetics. Are you routinely prescribing them, and is insurance covering it?
Yeah, two separate questions. So the good news is you heard about the FDA. The FDA has approved one of the, there are many now, there are half a dozen SGLT2 inhibitors, but one of them is now approved for use in heart failure. So yes, I am in reduced ejection fraction heart failure, the people with low ejection fractions. It is now considered cornerstone of therapy. It's one of the 4 drugs we try to get everybody on. Drug companies are supporting further research in this, but yes, they are being paid for even in non-diabetics, and anybody with low ejection fraction heart failure should talk to their docs about going on to an SGLT2 inhibitor.
And a similar follow-up question, are you prescribing colchicine for patients without gout, and which dose are you starting on?
So these studies literally have just come out in the last 4 weeks, some of them. And I think the answer should be yes. One of the problems with colchicine is a cost procurement. So you've been in practice long enough that you know that a few years ago, colchicine was pennies per pill. And because of an oddity of the FDA and an oddity that colchicine had been around so long that nobody had done a clinical trial and actually gotten FDA approval, it is now considered a non-generic medicine, even though it's been generic for decades. And hence the procurement cost, instead of pennies per pill, is many dollars per pill. And that's an impediment when you're putting people on medicines for the rest of their lives. And I believe that patent covers colchicine for another 4 years or so. So we're in a little bit of a pickle, but I think in a perfect world, would I recommend everybody be on colchicine if they have documented coronary disease? I would. Whether everybody with high risk, don't know. You heard Dr. Weinberg talked about calcium in the coronary arteries. I think people with coronary artery calcification, we should significantly increase our use of colchicine in such people.
Great, thank you. And then a couple of questions for Dr. Billingsley. One is it better to always request brand name only medication? Should I assume it's the best option? And then kind of similar to that, how safe are drugs from overseas? And should I assume my brand name medication is made in the United States?
So those are both great questions. So I would say no, you don't necessarily always need to request the brand medication. As I've covered, the generic medications are modeled after the brand, so they should work the same way and get the same benefit as the brand medication. Now that said, it's no secret that the prescription drug pricing in the US is not very transparent. Medications tend to be more expensive. Insurance plans also have their own formularies where they prefer certain drugs over the other, and generally the generic is the preferred medication. So prescribers may default to those generic alternatives just because they tend to be preferred. It's less of a back and forth and hassle, with the insurance company. They should work the same, provide the same benefit, as well as be more affordable for patients. So now that said, as far as if drugs coming in from other countries are safe, as I've covered, a large percentage of our finished drug products and raw ingredients are coming from other countries, and these facilities are required to comply with the same standards as the facilities in the US. But as we've noticed, there are some challenges in monitoring compliance from these facilities. And so particularly with the inspections, the FDA has worked to fill in a lot of these gaps, including working more closely with their offices within those countries. And also keep in mind is that when these issues like the nitrosamine issue that has come up and being investigated by the FDA, other countries are also importing these drugs or having these drugs manufactured in places like China and India, or where some of these issues are coming from. And so other regulatory agencies are also involved and working with the FDA to make sure that a lot of these issues are being addressed. Now that said, I don't know if it's safe to, or you could, confidently assume that your medication is, necessarily made within the US every time.
Got it. And do you know if pharmacies have a responsibility to notify patients and or prescribers about recalls, or do patients need to be researching this on their own?
So I think from a legal perspective, I don't believe pharmacies have a legal responsibility to notify prescribers or patients of a recall. That may also depend on your state regulations, and so there may be a requirement with that regard. But you could make an argument that there is a professional or ethical reason to notify your patients or prescribers if any medications that were dispensed by your pharmacy was potentially impacted by these recalls. And so I think, bottom line, I think, consumers really need to, be vigilant, as are prescribers and pharmacies, to make sure that these recalls are addressed appropriately. Removing some of these products from the shelves, having tracking mechanisms in place to capture the lot number and manufacturer being dispensed to patients. And that way you have a better idea of who's actually being impacted and communicate that more specifically.
Great. And there's a fun question here for Dr. Wright. I know you were the cardiologist to the great apes at the LA Zoo. As a tangent, can you make any comments about the use of these drugs in gorillas, or conversely, have doctors learned anything from the use of meds on apes?
Yeah, so thanks for the question. Yes, I did for a decade do the cardiology for the orangutans, gorillas, and chimps at the zoo. And the reason that they need a cardiologist at the zoo is because these close relatives of ours suffer from the same problems that we as adults suffer for Homo sapien disease. So they get coronary disease, they have heart attacks, they have atrial fibrillation, they get heart failure. I have, in fact, I'm one of the few people in the world ever to have done CPR on a gorilla. That was a gorilla that had ventricular fibrillation while I was doing a transesophageal echocardiogram on the gorilla. So have they been treated with the drugs we talked about? Yes. And the problem is, it's hard to get these, from your own dog. How hard is it to get your dog to take a pill? It's not that easy. And gorillas and chimps are smart enough that you give them these pills, they pick them out of their food and throw them out. So it's been a challenge to get them to take their medicines. But we fully expect, and in fact, there's a gorilla that had a stent. I know of a gorilla that has a defibrillator in place because of cardiomyopathy. So the same treatments we use are used in these close relatives, I believe, with success. So what lessons have we learned? We all get the same diseases, even though, and for those of you who think that you can avoid heart disease by being a vegetarian, let me tell you, these animals eat the best diet you've ever seen. It's all fruits and leaves and vegetables, and they still get this disease. So You can't totally prevent it with diet alone.
Right. So if Dr. Wright talked about aspirin, another question for Dr. Billingsley: how safe are over-the-counter medications and supplements like your aspirin or other supplements? Is there any sort of regulation in the US for those products?
So there are, some regulations with that regard. It's a little more loose than with the prescription drug, approval processes. And then you get into the over-the-counter supplements that are regulated by a different act altogether. And a lot of the onus is on those facilities manufacturing those products to ensure their safety and their labeling and all of that as well.
Okay, and then we had multiple questions about the chewable aspirin. I think the biggest question was, if I have history of gastritis or ulcers or bleeding risks, am I okay taking a coated aspirin?
So let me give you my 1-minute elevator speech about this. A total myth. People think that aspirin irritates the stomach. It does not. The way that aspirin causes bleeding is a systemic effect. So I'll give you the perfect example. If you squirt aspirin into a vein, intravenous, which they have in Europe, we don't have it in America, the same percentage of gastric upset occurs as people taking oral aspirin. It's the systemic effect of aspirin. It's not the stomach effect of aspirin. So hence, aspirin works systemically. That's how it prevents heart attacks, but it also does cause gastric upset in 1 or 2% of people. The reason you don't want to take coated aspirin is, I'll give you the perfect experiment. I'll give you aspirin that I coat in stainless steel, and you'll tell me it was perfectly tolerable. I didn't have any upset stomach, except it'll be perfectly inadequate. It doesn't get absorbed and it doesn't work. So non-coated aspirin, when pitted against, for example, IV aspirin, has the same stomach problem. 1 or 2% of people get gastritis. In those people, you have to use some other agent. There are other antiplatelet minor blood thinners like clopidogrel that don't share that stomach upset problem. So it's not due to the coating. The coating only prevents stomach acid by preventing absorption.
We have a couple more minutes, or maybe one more question here. Dr. Billingsley, when do you expect the COVID vaccine to be FDA approved, or what steps will be required for that to happen?
So I think we could potentially expect to have, at least one approved probably this year. So whenever these companies, go through the emergency use authorization process, the FDA actually does have guidance for whenever you're approaching vaccines, some of the testing and the treatments. And so with regards to the vaccine, there's generally like a 2-month follow-up period before they can file a request. So looking at the AstraZeneca vaccine, for example, I believe the second doses were administered towards the end of January. And so generally there's like a 2-month waiting period as far as when most of the events would happen. And so at that point, probably towards the end of March, we'd have AstraZeneca applying for an emergency use authorization. And these companies can decide to continue on with their phase 3 clinical trials so that they can apply for licensing. And so rather than actually going through the new drug application with vaccines, they are considered biologics. And they file what's called a biologics license application, or BLA.
Great. And we have 1 more minute. Dr. Wright, if you can answer quickly, if people are on SGLT2 inhibitors, can they consume as much sugar as they like, or is there a form of having increased glucose in your urine?
Yeah, I mean, obviously, there are lots of issues with too much sugar, one of being is your waistline. So no, I mean, we don't want people to embark on eating more carbohydrates. And you will eliminate more glucose. It's correct. You're going to eliminate 300 grams. Remember, one of the advantages of the SGLT2 inhibitor class, it's one of the few diabetes drugs that lowers weight, because if you waste calories every day in your urine as a diabetic, you will lose weight. So that is a big benefit for obese diabetics. But please don't then get free license to go out and go to Krispy Kreme every day.
Great. Thank you so much, Dr. Billingsley, Dr. Wright. That was great. So
Our pleasure.
Thank you.
we would like to take a moment now to thank our sponsors for their support for this meeting. Many of these companies have been with us since the first Women's Heart Symposium. Thank you to St. John's Foundation, Medtronic, Abbott, and Solve Healthcare. A special thank you to Within3 and DOJ Designs, who helped us tremendously with this first-time webinar.
We would also like to take a moment of silence to remember one of our own that we lost this year. Beverly Self was an amazing woman who we featured in a video on the homepage of our website in light of her remarkable story and true zest for life. We feel lucky to have had her in our lives.
For our last surprise, we have another guest speaker. She will share her story as to why her focus has changed from law and order to cardiovascular disease. She is helping us to spread the word on how we can live forever.
Hi, I'm Elizabeth Rome, and I'm so honored to be asked to share in the Women's Heart Symposium about my personal story of why I became an advocate for heart disease, heart awareness, heart health, and especially women's health. So thank you so much for asking me. My mother 11 years ago died of a massive heart attack, much too young, far too young, and it has become my life purpose to help educate women on how to take care of their hearts, because we need the women in our lives, and also to encourage CPR training and just more awareness. So I just want to say thank you so much for having a heart symposium. Thank you for inviting me to be a small part of it. I hope that each of you will advocate for the women in your life to know more about heart disease and keeping your heart healthy and staying aware. So thank you so much. And I wish you guys a great experience together, an encouraging experience. Bye.
As you have learned, staying forever young is not about one thing. Whether you sip green tea, wear your face mask, stretch with your exercise bands, or use your face roller to roll your way to the fountain of youth, it is important to make sure that your insides match your outsides. You need to find the right balance of what your body needs to achieve good health as you continue to live longer. We thank you so much for attending our meeting today. It was really our wish to provide you with some fun and know that we honor each and every one of you. If the darkness of this year has taught us anything, it is that you are here for a reason, and we hope you don't take that lightly. We want you to take this knowledge and all the fun that surrounded it and pay it forward. If we spread this message of health, we can all be forever young. We look forward to seeing you next year in person for our 9th annual meeting.